course, of the delivery. But the entire process of the labor and delivery is that's expected date of confinement, wherein we expect, of course, the labor starts. Okay? So what is, of course, the labor and delivery? What's the term, of course, that we do? We with the term would begin. Parturition or para. So that meaning to say, when I speak of para, there's a parting, of course, of the baby of the baby from the mother. Then there's the process of para we're going to talk about. We talk about gravida, the normal gravida process last Monday. Today we're going to talk about para. What are the things, of course, when it is due? Okay? So when it is due, of course, when the woman is due, at least, of course, the gestation or the age of the fetus in weeks will be at least completed, of course, 37 weeks. If the pregnancy is only 36 weeks and 6/7 days, it is still technically considered premature. It should be completed 37 weeks. Even if it is 36 weeks, 6/7 days, 23 hours, and 59 seconds. So technically, that is premature. So again, completion of 37 weeks. Okay? In the term, the age bracket, of course, that we refer to, if it is abortion, will be before completing, of course, the 20 weeks of gestation. Okay? So anybody who's born completed 20 weeks of gestation and before completing, of course, 37 weeks will be premature. Okay? So anybody who is born, of course, out more than, of course, 42 weeks will be, of course, post-term. Okay? So those are the technical terms, of course, that we use. That's why in para, we have tipal in terms, of course, to age. What is the baby, of course, is all about. Is it the baby full term? Is it the baby preterm? Is it abortion? Okay, that's it. And then how many living children? That's why we have FPAL or your tipal. Okay? So now labor and delivery. So there's a process we're in. The baby now will be separating from the mother. Okay? Irregardless, again, here, of course, we are not talking about, but this is the normal one. Therefore, we expect, of course, the occurrence, the age of gestation here is about 37 weeks. Okay? Even the process of premature delivery, it's still almost the same. But the only thing for that one is that survival rate, of course, of babies born below 37 weeks is lesser. And there will be a lot of complications, and we're going to talk about it one when we encounter the newborn that has complications. But for now, we are expecting, of course, a healthy baby and a healthy mother, which is, again, the goal of care for a prenatal care. Isn't it? Healthy mother and healthy baby. When we speak of healthy mother, and it means, of course, that both physically and psychologically and emotionally. And again, when we speak, of course, of baby, we don't have any complications. Or meaning to say that pregnancy and the delivery is low risk. That's why, even if nurse midwife, of course, could take care of both the prenatal as well as, of course, the delivery. So birth attendants, first one is that we have, of course, your physician, certified nurse midwife, okay? NP and PA could be questionable depending, of course, probably on the state, okay? But the most two common person who can handle delivery will be, of course, your physician or your OB, plus, of course, the second in line will be your certified nurse midwife. But as I've said, to be specific, physician can handle everything, even surgery, OB surgery, which, of course, commonly, of course, will be C-section or cesarean section. CNM or certified nurse midwife, provided the pregnancy is normal, or shall we say the term normal will be, of course, strike out. It will be, of course, low risk. Okay? Low risk pregnancy and low risk labor and delivery could be handled by the CNM or certified nurse midwife. In any event that the risk or complication or probable complication rises during the process of labor and delivery, then it should be referred, of course, to the care of the physician. Okay? Nurse practitioner and PA, commonly these are the people who could handle normal prenatal care, but more or less with the delivery, there's a doubt, of course, if they could handle the delivery. Okay? Okay. So another one is that the labor, when we speak, of course, of labor, the series of events during which the woman's uterus contracts and expels the fetus and completes the birthing process. Okay? So that's the labor. Okay? So the labor will be, of course, usually, of course, it's a process wherein until such time that the fetus will be expelled from the uterus safely. Okay? It is a normal process. So another thing is that the intrapartum. So again, before we have the prenatal. So natal will be the birth, or pre-antepartal, meaning to say that it is before the birthing. So when we speak of intrapartum, in the middle, inside, of course, the parturition, meaning to say the labor, the process within, of course, the separation of the baby. So this is the time period which labor and delivery begins. As a matter of fact, labor is the process, of course, in which, of course, expelling the baby. When you expel the baby, we call that process delivery. So labor and delivery, of course, is usually, of course, a continuous process. Okay? Takes place. The postpartum will be the one, of course, when we deliver the product of the pregnancy. What are the products of the pregnancy?
Baby and
First one is the fetus. What's the other one?
mom.
Placenta. Do not forget placenta, because placenta is part of the baby. It's a baby's part, and therefore it is a product, of course, of pregnancy. By any chance, these two things should be delivered out, or else we cannot complete, of course, the involution, or the uterus, of course, will be at risk for bleeding. Remember, the baby and the placenta are not part of the mother. They are foreign bodies. They have to be expelled by the placenta. Any remainings or any part, however minute, in the part of the placenta that's retained in the uterus, okay, the uterus cannot close, okay. They have to be expelled in order, of course, for the surface, of course, in the endometrium, of course, of the uterus to close and to contract. Any remaining, any process, of course, of placental fragments equals the uterus cannot contract and cannot close the blood vessels. What it will result to only one thing: bleeding. Okay? That's why later on, as a part, of course, of the nursing, of course, responsibility with the placenta will be expelled, we have to examine the placenta for possible, of course, absent surfaces. Okay, so we have to approximate if there is, of course, if the placenta was delivered completely. Because in any event the placenta is not delivered completely, we got a problem. Okay? So that's it. The postpartum, that will be, of course, the focus. The focus of the postpartum primarily is to make sure, one, placenta was delivered properly, because again, the end, of course, of the delivery will be the delivery of the placenta. Postpartum, usually, technically, will be the first 4 hours after the delivery of both the baby and the placenta. Okay? So, although it will extend, of course, until, of course, 6 weeks, because the process of 6 weeks, of course, will be very important. So that the goal there, of course, is that to maximize, to allow, of course, the body, the system of the mother, to go back to pre-pregnant state. Okay? So, because again, we would like, of course, to condition that the goal for that one always will be not, of course, to destroy the capacity of the mother to be pregnant again. Therefore, we have to bring back healthy and healthy-wise, of course, the system of the mother into the pre-pregnant state. Okay? That will be the goal for postpartum. Now, we have a birth setting. First one will be the hospital setting. So usually, commonly, of course, we have labor room and delivery room. These are separate things. Okay? So a woman could labor, of course, in the labor room. We check if the birth is imminent. Shall we say we are fully dilated? Later on, we call the cervix is fully dilated, which is around, of course, 10 cm. Okay? If that will be the case, then the woman should be assisted to the delivery table or the delivery bed, in order, of course, for the woman to give birth. Okay? So, but right now, the advancement will be, of course, the traditional labor delivery unit. Right now, we have LDRP, so Labor Delivery Recovery Postpartum Unit. The good thing about it is that the woman need not to be transferred. So once the woman is, of course, in the peak of the labor, shall we say in the transitional stage, of course, of stage 1, of course, of the labor, it will be, of course, just crack down, of course, the foot part of the bed, and then elevate, of course, the legs, of course, of the mother to stirrups. So we have, of course, your lithotomy position. Why lithotomy? In order to prevent strain, of course, to the dorsal side, of course, of the mother. We have to elevate it. That's the safest way, of course, so that, again, there's no much injury to the mother and to the baby. Okay? So LDRP, sometimes we have birthing rooms, of course, in the birthing centers. Room for both labor and delivery. So birthing rooms, and then right now we have LDRP. The second one, birthing rooms, will be labor and delivery. You will be there. And after the woman, of course, delivers, the woman, of course, will be transferred to postpartum 1. That's only for birthing. Okay? But right now, we have already, of course, your LDRP. LDRP, which is the most common standard if you are going to hospital setting. So usually in the LDRP, that's also, of course, the place usually that the woman, of course, will be discharged or stabilized. Or that will be, because it's being utilized, of course, for labor and delivery, so you could be, of course, stepped down, of course, to the postpartum unit. And usually the baby will be, of course, admitted, of course, to the neonatal unit. Okay? So birth centers, the birth centers will be, of course, the one, of course, the most practical in terms of, one, standards, of course, of care in birthing. Another one is that it is economical, cost effective, because it is not a big hospital. So we have, of course, a lot of birthing centers that offers, of course, the services. Okay? And again, another option that's growing will be home birth. So as long as the pregnancy is not high risk, then home birth will be allowed. And it could be, of course, under, of course, the guidance, of course, of a certified nurse midwife. Okay? Barely, of course, obstetricians goes home for home birthing. It is not, of course, 1970s, 1980s, wherein, of course, the doctor has to walk in the foresty areas to reach, of course, the home, and then the doctor will be assisting the delivery. No. So if you will be, of course, needing, of course, obstetrician, the standard, of course, will be you have to be admitted in the hospital, or at least a birthing center. Okay? Where the doctor, of course, has all the amenities, and we have all the stuff to take care, of course, of the woman who will be delivering, of course, who will be laboring and delivering, of course, in a very, of course, standard environment. Okay? Birth plan, as I have said, the woman should have possessed one. So usually, this is being expressed, of course, and usually the OB will gonna guide the woman how to reach, of course, birth plan. What are the contexts of this birth plan? So the expected mother, as I have said before, birth plan will be who will be going to be there during the labor and delivery. Where is the woman going to deliver? Is it home birth, birth center? Is it the hospital? Okay? And who are the people to be present there, of course, as requested by the woman during the delivery? Is it the husband, the mother, or the doula? Okay? Or another one is that, what are the mode, of course, of pain management? When to give anesthesia? Okay? Does the mother request, of course, for anesthesia, or the woman, of course, is too stoic, okay, to suffer, of course, the pain, or to experience the pain, of course, of the labor delivery, okay? So that everything for that one, and then what will be, of course, the options, of course, for the baby will be the mother breastfeeding, because again, our care for the woman who gave birth, who is planned to be breastfeeding, will be, of course, we have the rooming in procedure when the woman, of course, has given birth. But if the woman decided not, of course, to use the breast, of course, to support the baby, or there is possible complication, of course, that the woman is not allowed or recommended not, of course, to breastfeed, of course, then, of course, it will be part, of course, of the birth plan. So the birth plan, of course, will be guided, and it's part, of course, of the chart that the woman wishes. These are all what the woman wishes to happen during the pregnancy. Before the woman, of course, could reach those decisions and plans, then, of course, an obstetrician and a nurse should guide the woman in reaching, of course, the proper decisions. Okay? And as nurses, our goal will be, of course, to follow the wishes, of course, of the birthing mother. Okay. So, we have stages, of course, of labor. So, again, the labor is the process we're in. The product of conception will be expelled. Therefore, we speak of labor, and we have, of course, the stages. We have 4 stages, isn't it? Stage 1, stage 2, stage 3, and stage 4. Okay? Stage 1, dilation. We call it one. What is being dilated? Or what is dilating? It is always, of course, your cervix. Again, the door has to open, okay, in order, of course, for the baby to come out. Remember, the cervix is constricted. It's very close. Therefore, it has to dilate in order to allow the passage, of course, of the baby. Or else, the baby cannot get through of that neck of the uterus. Okay, it's the dilation. It is, of course, presented in 3 phases: latent phase, active phase, and transitional phase. Okay? So once it's fully dilated, now it is stage 2 will be expulsion. Expulsion will be the delivery, of course, of the fetus itself. Okay? What is being expulsed, it will be the fetus. It is usually, of course, it's just very rapid once the baby is out. Once the baby is out, so again, the goal for care, of course, for that one will be, usually there is another one who will receive the baby to take care of the baby. As you can see in the usual delivery, if the RN that is assisting the OB, of course, to deliver the baby, once the baby is delivered, because suction that one, once they remove the baby, it will, no, the care for that one will be another nurse. Therefore, there's always a receiving nurse. And this receiving nurse is usually the one that works in, of course, in the neonatal unit. Okay? This nurse, of course, will gonna receive, of course, the baby under, of course, the radiant warmer. Okay, we call that one, and clean the baby and stabilize, of course, the baby, and to assess the baby right away. Okay, so and usually, of course, later on with the mother and again the doctor and the primary nurse who is attending the delivery, we're gonna go to the next phase, the placenta. So it will be managed, of course, in order to take, of course, make sure, of course, that the placenta is fully delivered. Okay, so that's the goal. And of course, after the placenta is delivered, okay, so these are the things, of course, we have to know. What are these phases? What are the things that we do? How do we know, of course, and probably how long? Okay, expulsion. How does, of course, baby comes out? Okay, and placenta. Or what are the 2 forms, of course, of placental delivery? And another one for that one is that later on, the thing you have to memorize will be what are the signs that you will know that indeed the placenta is being expelled? Okay, so or we call it one is that usually the signs, of course, of placental delivery or separation of placenta. Okay, the recovery will be once the placenta is delivered, it is complete. Again, the first 1 hour into 4 hours, of course, after the delivery is very, very critical phase. We call it one as stage 4. Okay? The stage 4 will be to make sure, of course, that the woman has no complications, of course, of postpartum. the number one of that one will be to make sure that the woman is not bleeding. Okay? Bleeding, continuous bleeding, is a major complication of course of postpartum care. And in the postpartum care, as we go along later on, we have to note what are the color of the discharges coming from the vagina. What is a very important thing, of course, to note if we have some complications or not. Okay. So now, there are three things, of course, in order to refer to the baby. First one is lie. Okay? Lie is a term used, of course, to compare the position of the fetal spine to that of the woman. Therefore, there are only two fetali, either longitudinal or transverse. Okay? So if this, so of course, if this is the woman, okay, if this is the woman in this the pregnancy, okay, just think about it. This is of course the spine of the woman here, straight, isn't it? So if the position of the baby is just like this one, the spine and spine goes along together. Is that correct? So we call that one longitudinal. But here I have another term: lie, presentation, and position. So, but again, there are two forms. Here, along of course the baby's spine is the same along of course the mother. It could be of course that. It's the longitudinal, isn't it? Meaning to say, of course, along the spine. These two, of course, as long as it is longitudinal, the only one important thing, birthing through the vagina is possible. Clear? If this is, of course, this one, it could be, this is what we call breech presentation, because it's the butt, breech, butt. Okay? Always remember that. But sometimes it could be footling. If it is footling, it's still breech. Okay? Because again, the feet part or the bottom part will be the first. Okay? Here, cephalic presentation. We call that cephalic presentation because the head first, isn't it? But commonly we call it one vertex presentation. Meaning to say, normally, in the normal condition, it should be head first. Okay? But you know, along the process, the baby growing inside could float and reposition himself, okay? Or herself. Therefore, it could be later on breech. But in terms of lie, we call that one longitudinal lie. Okay? Another one, of course, shall we say, if the pregnancy, of course, just like this one, what if the position, of course, of the baby will be
Sideways.
like that?
Transverse.
So again, the spine is transversing, of course, the mother. So the fetal spine is transversing. Okay? And commonly, if this is the presentation, we call it one transverse. Okay? We call it one transverse lie. And by any chance, transverse lie cannot be delivered via vagina. We have only one way of delivering this one, C-section. Okay? And with this one, the presenting part commonly is the shoulder. It is a shoulder presentation. If it is a shoulder presentation, by any chance, the risk for delivering it through the vagina is very, very, very low. Okay? Therefore, of course, that's why, if it is, of course, transverse lie, you don't have any choice. In the normal context, it should be C-section. Okay? And just imagine if the woman is in the middle of the jungle, no access to healthcare, no access to hospital, in the lie will be transverse in the shoulder presentation. And believe it or not, at that time, commonly, it will be, of course, the death of the baby in the mother. Okay? So again, if it is a bigger head, as long as it's head, our cultural midwives, of course, of Africa could break the pelvis, but this one, it is very, very hard. Okay? The only way to do that one, sometimes the attempts will be repositioning, not only external positioning, but usually, of course, they have, of course, a gloves until here. Some doctors could push it down and reposition the baby, provided the baby is not engaged. So these things, of course, usually, of course, the baby cannot engage because of the fact, of course, that the baby cannot descend properly. Their only way to descend, either the legs, the butt, or by the head. This one, it will not go past, of course, the stations. Meaning to say, the ischial spine. Okay? So that is your transverse line. So presentation, as I have said, what is the presenting part? So again, we speak of the presentation. What is, of course, lies closest to the pelvis? So again, if you take a look at, of course, the baby through the vagina, what you see first is the presenting part. Okay? So is it the butt? If it is a butt, we call that one, of course, it's opposite. So we call it breech. The normal presentation should be, of course, your cephalic presentation or head first. Okay? So we call that one cephalic face presentation. But sometimes, I don't know, because the fetus might be so proud. So instead, of course, of flexing the head, the fetus, of course, is doing this one. So instead, of course, of the occiput presentation, we call the one. The first part will be the longest part will be the occiput of the baby, which is normally, of course, the one that is presenting. But sometimes, because there's tilting of the head, it is the brow. It is, of course, the chin, of course, that's presenting. Okay? It could be the brow, it could be the chin. And those are, of course, very, very hard, of course, to deliver. If that will be the case, second twice, commonly, of course, it will be C-section, unless otherwise the baby could be repositioned, if it could be repositioned. Okay? So, but as long as the head first, it could be the presenting part will be the occiput. Okay? It could be, of course, the brow presentation, or it could be, of course, the chin or menton presentation. Okay? The breech presentation will be butt first. Breech, butt. So it could be full breech. It could be, later on, we're going to be saying, of course, what is full breech, okay? What is, of course, kneeling? It's sometimes the baby could kneel. Or sometimes, believe it or not, the baby is modeling already. Flex one, the other one is straight, and only one leg is coming out. We call it one footling. A footling, of course, is a breech presentation, which is, of course, either one or two of the legs will be coming out first. It will be better, of course, if both extremities, the most common one is that I delivered a lot of babies who are footling, only one, okay? So it is very hard, of course, to deliver because you can pull it out because, again, the knees, of course, and the hip are flexed, okay? So there are some tricks, of course, to deliver that one in order to push back, of course, again, the feet of the baby, and then grab, of course, the other foot in order, of course, for it to be delivered properly, okay? And this one, fetal presentation. Mentum, it is, of course, it is the sacrum. If it's a butt, always the presentation will be the sacrum. This is the reference, okay? Left occiput presentation, okay? Left occiput, this one. Okay, so that's one thing. The first thing, of course, that you can deliver in terms of occiput will be, if it is, of course, posterior. If it is okay, of course, left occiput anterior, it should be. Because if it is left occiput anterior, the tendency, of course, of the baby is, of course, to extend the neck. Just imagine if it is the opposite around. If the occiput will be here in the posterior spine of the woman, the baby cannot extend. If the baby cannot extend, so therefore it will not pass. Because remember, the fetal head will be, of course, elongated, and it is in the occiput part. Therefore, the occiput has to go out first. So the normal condition will be either right or left occiput anterior. If it is occiput posterior, it is also very, very hard to deliver. Okay? So another one will be, of course, your mento presentation. When we speak of mento, it will be the chin, of course, or the face. Okay? And, of course, your sacrum. So station. So when we speak of station, the level of descent of the presenting part into the birth canal. So measured as the relationship of the fetal presenting part of the lowest part of the woman, based, of course, on the woman. Okay? Here. So usually the fetal head in normal presentation like this one, it will be, of course, that the fetal head will be floating. Okay? So we need to say, of course, when the woman is delivering, of course, nearly or towards delivery, the baby will be ready to come out. Usually, the baby, of course, will descend. Okay? And once it descends, it progresses here in this level, of course, of the ischial spine. Okay? -3, -3, -2, -1. When the head, of course, is at the level, of course, of the ischial spine, it means to say, of course, that's 0. Okay? And 0 means it is fully engaged. And usually, if it's fully engaged, you cannot remove the fetal head already from the pelvis. Remember, these are bones. So the fetal head is locked. Therefore, the only way, of course, to get out is through, of course, the pelvis. No coming back. Okay? So the tendency of the baby is that the fetal head will be adjusting, reshaping, as you can see later on when the baby is out. Sometimes, of course, the skull of the baby is overlapping in order to allow passing, of course, of this very, very constricted area. Okay? So that's why we call that molding, all overlapping of the fetal skull in order, of course, to pass through this very narrow corner, the pelvic inlet. Okay? So now, +1, +2, +3. Okay? Sometimes in your book, you say +4, +5. Okay? So remember, if you are a nurse monitoring for the progress of the labor of this patient, if you feel, of course, that it's +3, going +4, going +3, going +4, call, of course, the obstetrician. Okay? Always remember, in station, do not wait for +4, because +4 is on the floor. Okay, so the baby will come out. Although the baby there, we have station 5, but I don't trust it because the transition between plus 3 station, if it is 0, then of course inform the doctor. We have already +1 doctor, so the doctor has to rush in. But in this +3, the doctor should be at present in the woman because again, as I have said, +4 is on the floor. Clear? I would like, of course, to recall that one. +4 is on the floor. Therefore, at +3, the doctor should be there, of course, on the bedside. If she will be the one to assist for delivery. Okay? And at the station. So if we have station 0, the term for that one is that we have a fully engaged baby. So we need to say, there's no going back. The baby has to get out. And there's no way of getting out through, of course, the pelvic inlet. Okay? There are some adaptations, of course, of the baby. Believe it or not, the fetal body, of course, is very adapted, of course, to small spaces. Okay? And remember, because of the fact, of course, in the fetal life, okay, the fetal head is the largest part of the baby. Is that? So how long is the baby, of course, when the baby is out, when the fetal head, when the baby's head and the chest are equal? How old, of course, is the infant, okay? Or the baby that comes out? Because normally in the fetal life, the baby's head is always the biggest part. Therefore, during delivery, if you deliver the fetal head, you could deliver the rest of the body. Now, my question will be, when the baby is out, what age, how old is the baby that, again, the fetal head will be equal to the chest?
2. 5 to 7, sorry.
5?
5.
3 to 5 years, it should be, of course, 1 to
3 to
2
5,
inches
sorry.
bigger. The chest now is 1 to 2 inches bigger than the head. But I am asking is that when they will be the same? It should be, of course, 1 would be, I would accept 1, but usually, commonly, of course, it is in between 1 to 2 years of age. At 2 years of age max, it should be, of course, the same. Okay? If it is not, then we have, of course, again, the mark will be 2 years. If at 2 years, our fetal head is still larger than the chest, hydrocephalus. Very good. Now, don't forget about it because I will keep repeating and repeating those questions in order, of course, pedia could coincide, of course, with the concept, of course, of okay. Engagement, as I have said. So, nulliparous, meaning to say we speak a nulli. Nulli, null. Never been. Null, nulli, never been. So, if you are nulliparous, you never been, of course, having delivery before. You might be pregnant. If you are not pregnant, even for the first time, you are nulli gravida. Okay? If you are nulli gravida, then definitely you haven't been pregnant. But if you, the two terms, gravida and para. So if you are nulliparous, meaning to say this is your first time, and usually, because of course your body will be adapting the first experience, the time element, of course, is way longer. As a matter of fact, a nulliparous mother could progress the labor around, of course, at least 48 to 72 hours. Okay? Unlike, of course, parous, meaning to say the woman who is parous, meaning to say has delivered, of course, before. Therefore, this is at least the second delivery. So a woman who is, of course, has delivered more than 5 times will be a multiparous. Okay? So if the nulliparous, of course, will take, of course, 24, 48, up to 72 hours to labor. A grand multipara could, the labor and delivery could be, baby is out. Okay? Which is, of course, the risk, because there will be a risk for injury. Because you have to allow proper time for the adaptation of the fetal head, or else you're going to be hematoma and injuring, of course, the fetal head during the birthing. Because, again, you have to allow time for the fetal head to adjust in the pelvic inlet before giving it total delivery. Or if not, because the fetal head, the size and the presentation that will be, could, of course, you had to crack the skull, you could cause bleeding intracranially. That's why we have a lot, of course, of hematoma formation, okay? So in engagement, that's why I have said, if it is, of course, station 0, so station will be the fetal presenting part compared, of course, the ischial spine of the mother. If it is the lowest part, of course, of the fetal part, normally we want it to be the head, will be, of course, the ischial spine. We call it 1-0, meaning to say we have fully engaged fetus. And the baby now is ready for delivery. Okay. History for more than one birth occurs during labor. So these are our terminologies. Nulligravida, nullipara, primigravida. If it is the first time, the woman who is pregnant for the first time, primigravida. Okay, so primipara. If it is always, of course, the woman is a primi. So usually primi, commonly the term we use, of course, for a woman who is pregnant for the first time and will be delivering for the first time. Okay, multi-primi, multipara, grand multipara. Okay, so if the woman has been pregnant for the 19th times, the 20th pregnancy will be grand multipara. Okay, just like saying, who are you? Ah, that's my grand baby. Okay, okay. So possession. So the possession will be relationship between the standardized points on the presenting part. So the presenting part again, what is the presenting part? What is the baby's part that can be seen in the vagina, inside the pelvis? So just imagine, of course, the woman is spreading her legs and you see it from that perspective. What is the first spot that you see? It could be the fetal head. If it is fetal head, what is the presenting part? Is it the brow? Is it the chin? Or is it the occiput? Even if, of course, breech presentation, what do you see first? Is it the butt or is it the foot? Okay, but it could be still all breech, but again, what kind of breech? Okay, is it a full breech? Of course, we're going to talk about that one later. So occiput, chin, mentum. So the first one, of course, occipital, of course, chin or mentum. Okay, chin or mentum or brow presentation. They are all vertex presentation. Okay. These are vertex presentation, but again, the position will be occiput, or brow, or mentum. Okay? It is buttocks or sacrum. Okay? Therefore, this is, of course, your breech presentation. And if it is scapula, remember, the shoulders, of course, or the scapula presentation, or acromion. That's why left acromion anterior, LAA. Okay? Therefore, of course, that will be, of course, your acromion process or the shoulder blades. Okay? And again, the fetal lie for this one will be your transverse. Both of this one will be again longitudinal, could be possibly delivered vaginally. This one, of course, will be transverse, which is not compatible with vaginal delivery. Okay. And position, as I have said, is that this is based, of course, on the mother's position. Okay, which position of the mother? If it is, of course, towards the back of the mother, it is, of course, posterior. If it is, of course, anterior, it will be, of course, towards the front side of the mother. So again, when we speak of positioning, we are looking, of course, at the spread, of course, the pelvis, of course, with the woman, of course, is spreading her legs. So that will be the reference. If it is posterior, therefore, of course, it is towards the back of the mother. If it is anterior, it is towards, of course, the front of the mother. And again, especially the occiput presentation, we want the occiput to be in the anterior part of the mother to allow flexion, or not flexion, but extension, of course, of the fetal head to go out. Because usually, of course, the fetal head, the presenting part will be the occiput, and the baby, of course, in order to deliver the head will be push it out, and then, of course, extend, of course, the neck. Once the head is delivered, we're successfully, and later on, we don't have a part. But the only thing for that one is that the shoulder, of course, cannot be delivered towards the head because, again, these two parts will be, of course, in the ischial spine. So the tendency of the baby, whether you like it or not, the baby will adjust its position. So first one, the baby, of course, will be doing extension. It will be delivered the head. Once the fetal head will be delivered, the baby will turn. We call that one external rotation. Once it turns, deliver the anterior, of course, anterior shoulder and posterior shoulder. And then the baby, of course, will turn outside. So the baby, when you catch the baby, will be, of course, the baby, this part will be the head, the back of the head, and this part, of course, will be the baby's butt. Okay? So, but the baby will be supine when the full body, of course, of the baby will come out normally. Okay? But the baby will gonna pick on you. Hey. Okay? One moment. And then, okay, where are you? Okay. The baby usually does the mimic, of course, the movement, of course, of the fetal when they come out. And believe it or not, when the baby will be exposed, the first time experience it, it's spontaneous. I don't know why, stop. The only stopping, of course, that I delivered a baby is a breech presentation, which I have a hard time. Believe it or not, I delivered my first baby, I don't know if I told you, but I might told you already, when I was still in second year nursing college. It is an emergency delivery. There's nobody who can assist the woman, so I was there. I don't have even my OB bag yet. Okay, so I attended the delivery until, of course, such time that I called, of course, the midwife to assist, of course, for the baby. And the baby, and that was the first time that Apgar score, when the baby comes out, meaning to say Apgar score is the score that we give to the baby on the first minute when they come out
to gauge if the baby's survival will be high or low. And right there and then, if you have, of course, a score, that should be, of course, a perfect score of 10, okay? Believe it or not, later on, the score of the baby that I got, okay, when the baby comes out, is around 3. So if it's 3, what shall I do? I have to initiate neonatal resuscitation at second year, of course, college. But believe it or not, the baby now, of course, is 24 years old. Okay, it's not a baby because he got a wife and he got his kids of his own. Oh, man. So, for example, this one, some percent fetus delivery difficult, dangerous. Okay, some percent just like, of course, like posterior presentation. For example, it's a footling breech position. There is, of course, a chance that the umbilical cord. The only problem it is a breech is sometimes, usually the umbilical cord will gonna be preceding, of course, the baby. If that will be the case, usually the tendency of if the umbilical cord is trapped ahead of the baby, while the baby is pushing it out, even the fetal head, or if it is a breech, they will gonna, of course, put a pressure on the umbilical cord. The end product for that one is that while the baby is inside, the baby, of course, constricted and limited, of course, the supply of oxygen to his system. If that will be the case, the baby's tendency is to open the lungs and breathe inside. And we don't want it to happen. Because we don't want the baby, if that will be the case, the tendency of the baby, of course, is that it will gonna make the anal sphincter of the baby relax. If it is relaxed, the first sign, of course, you can see, of course, is that the baby will gonna poop out. If the baby will gonna poop out, it will be followed by the gasping behavior of the baby inside, and the baby will gonna swallow that poop, his poop inside. And we call that one meconium staining. It's a very big complication. We have to clear the baby's lungs if it happens. The same is true as that. So again, until the baby is out totally, and until the such time, of course, the baby's lungs is inflating or receiving oxygen, that will be the time supposed to be that we can stop the umbilical cord. Until the baby is not yet out and breathing, we have to keep open, of course, the umbilical cord to access still the placenta, because the placenta is still the breathing organ of the baby until the baby could breathe by its own. Clear? So meaning to say, if we are pushing, if the baby is pushing out, the umbilical cord should be on the sides. It shouldn't have the pressure, or else the baby doesn't have any access for breathing. If the baby could breathe, could the baby die in the process? Yes, they could. And we don't want it to happen. So that?
What do you do with the placenta if it comes before the baby?
What is that? Give me, of course, the scenario. I want the actual one before I could react. Now, what is the percentage? What is the problem?
If the placenta comes before the baby.
No, it cannot. Usually C-section. The baby will die. We call it one placenta previa. Okay? And usually we grade it if it is complete occlusion, meaning to say you cannot deliver it, of course, via vagina. Remember, if the placenta is first, especially we call it one placenta previa, good thing, of course, if the baby, of course, still be carried over to full pregnancy. If not, it cannot be delivered. The only way, of course, to deliver that one will be, of course, through C-section. Because again, by hook or by crook, there's only one way of birthing. Again, baby first. Clear. Placenta next. Therefore, by any chance, even if it is C-section, it is vaginal delivery, we want the baby out first. Before, why? We want the babies to get the air first before we cut the source. Just like scuba diving. You let, of course, a scuba diver do not cut the source of oxygen. That's the umbilical cord. If you cut it before the diver comes up, what will happen? The diver will gonna die down there. Clear? That's the principles. So one thing for that one is that to get to the gross picture, if it is a low-lying placenta, the chances, of course, it is severe placenta previa, shall we say more than 70% occlusion, or down there, of course, in the cervix. There's only one way to deliver the baby, C-section. And another problem for that one is that because the lower end of the placenta, of the uterus, if 90% of the placenta is occluding, of course, the cervix, then it should be C-section. Another one is that if it is that low, the lower side, the segment, of course, of the uterus is not good enough. It is not having good muscles or endometrial muscles, myometrium, in order to constrict and stop the bleeding. In some chances, in most chances, I'm gonna bet for that woman who delivered, of course, with placenta previa, C-section, the baby might be alive. But in order to save the mother from bleeding, because bleeding is very high with placenta previa, we have to cut off the entire uterus right after we remove the baby. So we call that one hysterectomy right after delivery. Because if we don't do that one, the mother could die with bleeding. Because there is no way to clot, to stop the bleeding, because of course that portion of the uterus is so thin. The muscle is so thin. We need muscles, myometrium, in order to contract and press and put pressure on the closure, of course, of the blood vessels. Okay? But that's one, of course, I've seen that one. I've seen that one, of course, especially the lower placenta. Right away, we have to remove the uterus after delivery. That's the only way to save the mother from dying, of course, of bleeding. Okay? So those are the grave complications of pregnancy. And we're going to talk about that one, most of it, when we come, of course, next year. Okay? So lightening. So lightening will be settling of the fetus into the pelvis. Usually when we speak of lightening, of course, the baby, of course, will gonna be, of course, going down. Sometimes, usually the baby floats, swim around the amniotic fluid, isn't it? So the baby is swimming. Sometimes the daddy will gonna palpate, baby, how are you there? And sometimes, because of course, if you palpate on the other side, the baby will gonna move to the other side. So usually you can see sometimes the baby's foot is marking, of course, on the endometrium, okay? And you can feel the entire foot of the baby. The entire foot of the baby, or sometimes the entire hand of the baby putting the one in the uterus. It is just normal function because again the baby is still balloting, meaning to say floating in the amniotic fluid. But usually 2 weeks before the delivery, the baby will gonna settle just going down. It is not yet engaged. We call that one, of course, lightening. Lightening is just the baby is going down, of course, in preparation. It will be closer, of course, to the pelvis. Okay? The purpose for that one, of course, is that the baby should probably decide, oh, probably it's time to get out of this darkness. Okay? Okay, usually 2 weeks, 2 to 3 weeks before that one. Sometimes, if it is multipara, meaning to say a woman who has been given birth before, so usually not like that. But lighting, that will be settling at the bottom, we call it one. And usually once the baby is pushing itself out, and again, station-wise, it is inserting the presenting part, whether it's a foot or normally it will be the fetal head or the occiput, it reaching, of course, station 0, or the crossbar, of course, of the ischial spine, then we call that one engagement, and we call that one full engagement. Okay? So when we speak, of course, like how engaged is the baby? So we are talking about station. Clear? Okay, station. So that what is the station of the baby, or rather, what is the stage of engagement? You will say, of course, doctor, we have full engagement. So if you are talking about full engagement, you are talking about station 0. Oh, doctor, it's not only full engaged, it's already +2. Okay, so the doctor, if you're going to tell the doctor +2, okay, hold on. I have, of course, to attend to this delivery. And if it's +3, doctor, we are +3. So again, the doctor will gonna wait for +4, because +4 is what? He's on the floor. Okay? Or sometimes the book, technically we speak of +4. Okay? Usually you can see already crowning. Okay, the fetal head, usually crowning, we call that one if the presenting part is head. Usually we call that crowning. In the baby, you can feel the baby. Okay, right there and then. Okay, Braxton Hicks contraction.
Mr. Leo. So the engagement, I mean, the attendant nurse or in the delivery room, how do they measure it, or they just by looking at it and they can tell that is that 0, 1, or 2? Do they have a measuring point, or they just look at it all?
Okay, this is your tool.
2 means.
As a man, you know how to use this one, isn't it? Mr. Jones, okay? So if you're a nurse, you have to know whether you're a man or... My fingers, I have to say, of course, we call the word SVE, sterile vaginal examination. I inserted my finger to severals, okay? I cannot count anymore, countless, okay? Sorry, but the purpose for that one is delivery, okay? It's different. It's different. So again, that's why you will be taught again later on, because you can do that one only if we have already an open cervix. So later on, the changes we're going to talk about that one, just like, when do you know that this is already +2? Sometimes the doctor will, oh, you're only +2, you can go home. So the woman could go home. But then sometimes if there's no complication, the woman will go home. Come here when you are +8, when you are already +8. So when we speak, of course, of 8, 8 will be 8 centimeters. So meaning to say you have to stretch 2 fingers in order to accommodate, of course, for the fetal presenting part. So if it is a fetal head, you can, because again, the angle of your spreading, if you have 2 fingers, you will know. The depth of your insertion. If you insert the vagina, you will know, of course, where it is. But again, when you insert that one usually, of course, you can feel the fetal head. So meaning to say, If you can feel, of course, the fetal head, of course, already how big is it, then you will know what is plus. If only you can touch it with the tip of your finger, you can see the fetal head, oh, it's too high still. That's why we're still +1. So that skill, of course, of assessing that one, you're going to get it over time.
Experience.
So usually you will get experience or we're going to, okay, insert. Usually my preceptor will going to ask me, what is our station? Well, still too far. So we measure, of course, from the vagina into the pelvis. I can touch already the tip. We are open already. So we need to, so when we speak of the open, we need to say we have our cervix already dilating. So it might be +1 or 1 or 2 cm dilatation. Okay, and then when this is progress bigger, therefore a +4, a +3. I of course usually assume if it is +3 going +4, it is already 8 to 10. A full presenting part, of course, that they're crowning will be a total dilation. It's 100% or of the dilation. We call it 110 cm. At 10 cm, we're going to talk about that later. The head now is already free of the lip that we're going to hold, of course, by the cervix. It could pass through. Okay, because again, later on, one trick for that one is that why we need, of course, to know the dilatation, the cervical dilation, okay? Because we want to measure, because again, if the baby's head we're going to pass through and not fully dilated cervix, what will happen to the cervix? It will rupture, it will be lacerated. And remember, we don't want to have a lacerated cervix, because a lacerated cervix equals injury and probability that the woman can never be pregnant at next time. So then we have to take care, of course, of the cervix, because the cervix will be the door to close when the woman is pregnant. So any injury for that one could cause, of course, the capacity of the cervix cannot carry the cervix the entire term of pregnancy. Therefore, some women, of course, has documented that if they have lacerated cervix before, there could be a history, of course, of abortion, because again, the cervix cannot carry the entirety of the pregnancy. Clear? That's the bottom line why we want a fully dilated cervix when the baby is out.
Thank you.
Okay. Your fingers will gonna tell you. Okay. So I'm just saying. So, but that's the only way, because there's no way, of course, to see that one. You don't insert, of course, an ultrasound to see it. But the only way is palpating. It's palpating it, of course, with your fingers. And it will take some time. So signs of labor approaching will be, the first one will be show. The show will be the mucus plug. Remember, as I have said, when the woman is pregnant, the cervix is closed. How it is being closed? Just make sure, of course, it is a glue. It is, of course, a padlock of the cervix. Therefore, even the father's sperm, if she wants to engage in sexual intercourse during pregnancy, cannot penetrate, of course, the inside of the uterine wall. A Medicare, even a virus, cannot penetrate that mucus plug. That mucus plug has two purposes. It protects, of course, that the baby will not come out, or anything could come in. Okay? So the door is closed. That's when the woman is pregnant. It is primarily for the protection, of course, of the developing fetus inside. So once the mucus plug comes out, because, of course, of the irritation, of course, of the entirety of the whole of the cervix, usually you can see, of course, a little bit, of course, of show. That's why it's the common term, of course, wow, it's a bloody show. Actually, a show is bloody. Because, again, or pinkish, because, of course, of the fact that the mucus plug seals the cervix during pregnancy comes out. Just before labor, cervix opens slightly, this plug dislodge. Because some capillaries of the cervix rupture, staining sticky mucus or pinkish color. Indicates, of course, the labor begin. But again, I would like to oppose this one to the definition technically. Release of mucus plug is not officially the start of labor, although commonly observed it is. Okay? Because later on, if you will define, is the woman in labor? Because we have two forms of labor, true labor and false labor. And I have only one definition across the board of what is true, the beginning of the true labor. It is not even the show. I don't consider it one. Because the mucus plug could be released, there's a little bit of blood, but again, the cervix is not dilating. Therefore, it is not the beginning, of course, of the true labor. Clear? Okay? So the only definition of true labor I have will be, there will be some changes in the cervix. Two changes that will going to occur. Start of dilation. Another one is effacement. Even if the mucus plug is released, if there is no progression of dilation and there is no thinning of the cervix, that is not true labor. Clear? So although the usual process will be, if the show is being released, usually true labor precedes. Okay? But But the only thing for that one is that technically, in the technical definition of true labor, I don't want to accept that show to be the beginning, of course, of the labor. Okay? So meaning to say, a true labor is that contractions that results, of course, to changes in the cervix. That's my definition, of course, of true labor.
How early can you lose the mucus plug?
Huh? It could be, of course, believe it or not, it could be engaged, of course, after sex. Usually the woman is, of course, due to, sometimes the husband got to contain. They have sex in the course of the night. Mucus plug after the one because of the contraction of the uterus. Because believe it or not, sexual orgasm could cause, of course, the uterus, of course, to contract. As a matter of fact, there scholars have thought, of course, that in order to induce labor in women who are due, their doctors want for them to engage in sexual act, not only sexual act itself, but for them to experience orgasm. Because orgasm could cause contraction, of course, of the uterus. Contraction of the uterus could initiate through labor. So in that context, okay, without pun intended, it could be that they have sexual intercourse with the partner, and then the mucus plug released. But there is no changes, of course, in the cervix. Therefore, that's it. If it is only less than 1 cm or 1 cm without progressing to the next stage, it is not, of course, true labor. Even the mucus plug is out.
And then how soon can it go back? Or
What do you mean?
it has to go back and once it...
You cannot go back. Once you open the door, there's no way. You cannot open the door and get out, isn't it? Or you are outside, open the door and stay outside. Okay, so when you open the door, just like opening the door, there's no way. You have, of course, to come out. If somebody from the inside, if the door is open, there's only one way of going out. Okay? So what I mean, my definition for that one is that how long? It could be right there and then if the woman is multiparous. Okay? It could be another several 8 to 14 hours, believe it or not. Or it could reach to 72 hours. Again, is the baby safe? Yes. Because why? Placenta is still there. Clear? As long as the baby inside and the placenta is not detached from the wall of the endometrium, the baby is still safe. The baby is not yet in distress. That's why once the mucus plug is out, the best thing we could monitor is that you have to monitor, of course, the thing, of course, to monitor is that the frequency of the contraction, the interval of the contraction. Another one is that the biggest thing you have, of course, to note is that always check the fetal heart rate. The fetal heart rate should be within the numbers 120 to 160. Any heart rate, shall we say, below of course 100. So the example, 100 to 120, there's a discrepancy. If there is, of course, if it's 110, you have to do something. That is already presenting problem. If the heart rate reach, of course, below 100, you have a big problem right now. The baby could die. Do something. Clear? So the biggest thing, of course, is that once the mucus plug is out, you as a nurse will going to do SVE, provided, of course, there is no contraindication for sterile vaginal examination. If another thing that you have to monitor will be the dilation process, meaning to say you know the progress of labor. Okay? Another one to monitor is to make sure the baby is still alive and healthy inside. Therefore, one thing is that make sure that you of course have to listen, of course, for the fetal heart rate. In the hospital context, I'm going to present you how do we monitor it with all these gadgets, of course, in the hospital later on. Okay? But it could be right away. It could be another 8 hours. It could be another 12 hours. It could be another 24 hours. It could be another 48 hours. If it is primary, it could extend, of course, up to, of course, 3 days of labor. Okay? Labor is just a process. We have to reach, of course, the process, of course, when it's fully dilated and the baby is out. Okay? So I cannot tell you when to expect. It depends on the course of the progress of labor, and the progress of labor will be individual response in the body, of course, of the woman. The only thing for that one is that we have, of course, a range, but we don't know what's the specific. Therefore, the best way to do that one is that to know where the woman is, you have, of course, to make sure that you are assessing the woman. That's why when the woman is in labor, the woman, of course, should be assessed carefully. As a matter of fact, it's complicated. We have, of course, to check fetal heart rate. And the best one is that the highest priority when the mucus plug is open will be, of course, later on is that one way is that we can check, of course, the temperature, blah, 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 or whatsoever. But the most important thing, make sure the baby is healthy and safe. And one way to show that one is the heart rate. Okay? So that is your role. That is the first role to make sure, of course, that the baby is safe. Okay, show. False labor. First one is that, it hurts. So some women who are so all out or so vocal, you can hear a lot of profanities. Okay, usually the husband is usually, of course, the victim. Okay, But nevertheless, of course, when we speak of false labor, these are probably Braxton Hicks contractions. We call that false labor because, again, why false labor? The uterus might be contracting, but it does not result to two things: dilation and effacement. Clear? So any contraction that does not push the baby out and does not create changes to the cervix, two changes: dilation, widening, and effacement. When we speak of effacement, the cervix, of course, is very thick. It should thin as thin as the paper. Because again, why? Because we want not to injure, lacerate, of course, the cervix during the birthing, especially of the head. Irregular pattern. But usually, of course, when we speak, of course, of true labor, it is regular. And the frequency is getting closer and closer, and the duration of the contraction is getting longer and longer. Okay? The longer it is, the more progressive, of course, the labor we have. Here, irregular pattern. Sometimes it goes here, it keeps contracting again. Okay? No increase in intensity, no cervical change. That's the bottom line I want to accept as definition. So any contraction does not result to cervical changes, false labor. Whatever that will be. Even if it is regular, okay? Even if it is felt on the back, because true labor usually felt, if it's false labor, usually it is in the belly, going, of course, above. But if it's a true labor, commonly it starts on the back and radiating, of course, to the abdomen. Okay, that's the difference. Even if that will be the case, even if it's a regular pattern, even if it's increased in the intensity, but as long as there is no cervical changes, it is still false labor. The only definition of true labor I've got will be contraction that result to cervical changes. I would like to repeat myself, okay? True labor, rhythmic, grows stronger over time, begin true work of labor, and it's fairly regular. Until such time, of course, that intensity will be increasing, the duration will be increasing, and of course, the interval will be closing and closing. Okay. So we have some terms. Interval, time from the start of one contraction to the start of another contraction. Okay? Intensity, duration is the length, of course. Duration will be the length, of course, of the contraction. Okay? So here, of course, in the board, I have, of course, things for you. I'm going to use this one to explain where it is. In another one later on is that if we have some decelerations or abnormalities in pregnancy. This is, of course, the strength, okay, or intensity. Intensity, there's one way, of course, to measure intensity. There's no way to measure intensity even if we try, of course, to graph. The only way, of course, to measure the intensity of the contraction is to put your hand on the contracting of uterus, okay? So sometimes, do not push it. If you put it on, if you can still, of course, the hardness of the contraction. Clear? Right now, we don't have A&E, of course, unless otherwise we have, of course, to create, of course, we have to insert, of course, intrauterine, of course, catheter. That's the only way we could do that one. But right now, normally we could put your hands there in the abdomen, and during the contraction, that will be, of course, the time, of course, that you will know that how intense is the contraction will be. So if you feel that and there's no dimpling anymore, and you cannot create, of course, a dimple because, of course, the contraction is so strong, that is, of course, the highest peak, of course, of intensity. Okay? That will be the intensity. There will be, of course, the time. Okay? 0, no contraction. So again, if the contraction should build up, start, the increase in the intensity, of course, of the contraction equals what we call a short increment. Okay? Increment is the term. From 0, going up until it reaches the peak. The peak of the contraction is the highest and the hardest form of the contraction. And usually, the peak, of course, we call it one the acme. Okay? Did you read that one in the book? Increment, acme, of course, and once it slows down, will be, of course, your decrement. Later on, I'm going to repeat it myself. So again, when you speak, of course, of first one, interval. So the start of one contraction to another start of the contraction. So if the contraction starts from here, okay? And then, of course, a start of another contraction will be here. This will be, of course, your interval. Clear? Start of the contraction to the end of the contraction. We call that one a short duration. Okay? Why the uterus contracts? Because it will help, of course, thin out the cervix, we call it one effacement, and dilation or opening out, of course, the cervix. Okay. So you know what is false labor, isn't it? So that's the only definition I've got. And again, uterine contraction will be increment. So increment will be the start, meaning to say the contraction are getting stronger and stronger and stronger. So once it reaches, of course, the peak, the strongest part, we call it, once it is starting, it increasing, we call it one increment. And if it is reached the peak, we call it one as your acme. Okay? And once it relaxes, the intensity slows down, goes down, we call it one as your decrement until, of course, there's no more contractions. Okay? And this part, of course, will be the end of the contractions. Okay? The end of the contractions, and of course, now, of course, this is the rest period. Okay? This is, of course, the rest period. From the end of one contraction to the beginning of another contraction. But the interval, the start of one contraction to the start of the next contraction. That's the definition. I don't want you to do this one because this is only the resting phase. And again, the interval should be, standard-wise, it shouldn't be less than, okay? Less than 2 minutes. Okay, the time here, the interval, maximum, it shouldn't be less than 2 minutes. If you have a contraction that has an interval, of course, of less than 2 minutes, oh God forbid, the uterus will gonna be bursting out, literally. Okay, would it kill the baby? Yes, because again, once the uterus is contracting, the baby is not receiving enough oxygen. It has to relax. It has to pace itself properly, or else it will be killing the baby. Okay? And again, the duration will be, what is the duration? Normally, it will be 60 seconds. 1 minute, 60 seconds. From here to here, it should be 60 seconds. But again, it could extend for more than that because again, we want to expel the baby. Maximum is that any duration of a contraction greater than 90 seconds. 90 seconds is the number, then definitely it is abnormal. It will kill the baby. Okay? Therefore, maximum contraction, even if it is transitional in the transitional phase or before the expulsion of course of the baby, maximum 90 seconds. Okay? If it is more than 90 seconds duration, the baby now is gasping for air. Okay? Therefore, it should be more than, if that will be the case, either we have to relax down the uterus or else that it will gonna kill the baby. So again, interval not greater than 2 minutes, duration of not greater than 90 seconds. That will be, of course, the thing, of course, to memorize. And you have to memorize it by heart. And how do you know it? If you don't have any tocodynamometer, then definitely you have to palpate, of course, the uterus. Okay? Usually the old times, when I was still a student, they would say, okay, tell me when it starts to contract. When it starts to contract, I'm gonna put, of course, my hand there in the uterus, and then I have a watch on the wall. I have a clock in the wall, and time it. Okay. Oh, wow, it's strong. It's strong now. Okay. Duration. It stopped. It relaxed. So that's the entire duration, of course, of the contraction. Okay. Relaxation or rest interval, time between contraction. So that's of course your relaxation time. It is needed in order for the baby to suck all the oxygen he needs before the next contraction. Okay, report is one, as I have said before. To allow relaxation intensity, it will be mild, moderate, and strong, depending, of course, on the stage, of course, of labor. If it is, of course, shall we say, in the latent phase, it's fine. If it is, of course, mild, as you go along, it will going to go to moderate, okay? And it will be strong until the baby will be coming out, okay? So let the woman rate 1 to 10, just like your pain. What is, of course, the intensity, okay? So why we do that one? Because we call that one labor pains. It is painful when it contracts. But again, we don't want to use the term labor pains anymore. We want to use the term contractions. Okay? So how strong is the contraction? Intensity of the contractions, aka labor pains intensity. But here, we grade it to 1:10. Okay? In order for you to know, usually, the best thing is that you put your hands, of course, on the contracting uterus. The one way is that contraction by placing your hand on the uterine fundus or the upper curve, of course, of the fundus to know what's the intensity. Mild, able to press your fingers in the fundus, even at acme, so you can still press it during acme. Moderate, able to dimple fundus when you press in. Strong, uterine fundus feels quite firm, cannot press into it with the contraction at its peak. So meaning to say, once you press it, the fundus will gonna kick your finger out. Okay? You can feel it. It's very firm. Okay? Duration, frequency, intensity, length of relaxation time, client's reaction and statements. Okay? It's coming. Okay? And again, one thing for that one is that we never allow the woman to bear down or push when we didn't reach the certain criteria. What is the criteria? 100% effacement. No more lip on the cervix. So sometimes the thing, of course, before that we are using is that you do SVA. Okay, once you SVA, you can feel, of course, still, of course, a tissue that's overgrown on the sides. We call that one a lip. Okay, no, don't bear down, don't push it. We still have a lip. So we don't want, of course, if there's a lip, meaning to say it is not fully effaced. So again, it is congruent. 1 to 2 cm dilation, minus of 1 to 100%, it might be 20% or also 20%, of course, effacement. 10 cm dilation equals 100% effacement. Okay? So no more lip. Okay, you can bear down, no more lip is around, of course, 9 or 10. Okay, you can push now. We don't allow the woman to push without two things. At least 10 cm dilation and 100% effacement. Why? The goal will be, do not injure the cervix. Okay? Because if you injure the cervix during the time, just like, of course, that's why we want, of course, the pregnancy, the labor and delivery should be guided with somebody knows in order to prevent injury, of course, to the baby into the woman. Okay? That's why that's one of the most common reason, of course, that's like women, of course, we're going to push it out with a lip or with a still present cervix. So what happens? It will going to tear down the cervix. If it is not prepared, it will going to end up with spontaneous abortion to the succeeding, of course, pregnancies. We call it one, the term later on that we call it one is that the cervix now is incompetent. Incompetent cervix. Incompetent cervix is a cervix that cannot carry the weight of the gravid uterus until term. So it opens up because it cannot carry anymore. Therefore, it is always one of the reasons of spontaneous habitual abortion. What's that?
So they never get pregnant after?
They could, with the guy. But again, later on, we're going to answer the question next year. Okay? But there are some tricks how to, if they're pregnant, no to push.
No, lift the leg up.
No. We left their legs already when the husband is there in the front of them. So not anymore. The only thing is that cervix. We have to strengthen the cervix. And later on, the term we call that one circlage procedure. We have to put a ring in the cervix to close the cervix. Sometimes the ring that we do is sutured. So there's only one, if it is sutured, of course, the entire cervix, there's no only one way, of course, to deliver the baby, C-section. But still, the woman can still get pregnant. But normally, the goal here is that never cause injury, of course, to the cervix. Because we want, of course, a healthy pregnancy succeedingly. Okay? But again, to those questions, we can answer that one. There's some clinical interventions or surgical interventions that we can do for that one. Breathing techniques, pant. Usually, panting is the best thing, isn't it? Usually, when you are still in labor and don't want to bear down, we teach them, of course, even Lamaze method, of course, of birthing will be, okay, breathe with your mouth, pant. Just like that one. And usually the husband also knows because the husband is the primary coach. Okay? So usually they do that one vocalization, or whatever that one, or they sing, of course, whatever, of course, vocalization, or it will be pain medication. But the issue of pain medication will be, it should be included in the birth plan because, again, why? The most common pain medication we give are narcotics. Early narcotics could cause decreased progression of labor. Late narcotics, so it should be, of course, in a specific time period. Late narcotics given will going to cause CNS depression to the baby. And we don't want any depressed baby because it's very hard to stimulate the baby when the baby comes out. Remember, we want the baby to breathe when the baby comes out. If you give narcotics, CNS depression, respiratory depression, the baby doesn't have the drive to breathe, which is essential in order to expand the lungs. Yeah? Okay. Fetal lie, two-layered sac, we did, isn't it? What is, of course, the maternal side? What they call, of course, the fetus lies in a two-layered sac filled with amniotic fluid, okay, a bag of water. The amniotic bag, of course, will be, of course, on your side. The baby side, we call that amnion. Okay, the placental side will be, of course, your chorion, isn't it? Okay. 40 weeks, approximately 1 liter. Spontaneous rupture of membranes, meaning to say by nature. It will going to do, of course, SROM, breaking up the bag of waters without medical intervention, 25%. So if you don't touch it, okay, The bag of water, the amniotic bag of water, because of course the fetal presenting part, we're gonna push it out, it will gonna break. The only downside for that one clinically is that how long you gonna wait until for it, of course, to rupture spontaneously. And usually, of course, if you rupture that one, usually what happens is that you are giving, of course, a room for the fetal head or the fetal presenting part to push down on the pelvis. Therefore, what we do right now is that we rupture it artificially. Okay? So, but again, it occurs 25%. If you don't touch it, it will gonna rupture by itself, but only 25% of birth. All of the assisted births here in the United States of America, 75% we rupture it. How do we rupture it? Okay? With amniotomy. Amniotomy is the artificial rupture of the membranes. Why? The goal for the one is that to hasten the progress of labor. Clear? Because descent is enhanced if the bag of water will be, of course, ruptured. Okay? Done 75% of birth. As you can see, of course, it's like a hook. A hook. The woman will insert, of course, a 2-finger. Of course, always 2-finger. We cannot insert the entirety of the hand unless otherwise we're going to, of course, do repositioning. Okay? 2 fingers. The other finger, of course, we're going to be guided for that one. And usually what we do, of course, is that it's like, this is my amnio hook. It's thick. I'm going to put that one. Oh, gosh. I can feel now the bag of water. So I'm going to widen the stance. What I'm going to do is that from my gloved hand, I'm going to insert my, take a look. What does it do? Okay? Divert it. I don't want, of course, to injure the thing. I'll push myself here. There's my amnio hook. Where did that go? Underneath my finger. Okay, and then I'm going to push it and rupture, of course, the bag of water. And then I'm going to pull my hands out, protecting, of course, the amnio hook between my fingers. See? That's what that we do, of course, using the amnio hook. Okay? So what we do, glass of water. Remember, on the sides, okay? Or else you're going to happen, of course, on me, okay? A splash, of course, of Wisconsin Dells. It's so bad, but that's the first time and the last time it was happened to me. So again, wash out, of course, for the color of the amniotic fluid. Okay. Later on, the thing is that is when the woman comes to you in labor. So the first thing, of course, is that you have to assess everything. Is that you see, of course, if there's some discharges. The first question is that is the bag of water ruptured or not? So usually, of course, later on, usually we're gonna test that one because what we don't want to happen is that premature rupture of membranes, PROM again, passive range of motion. Okay, this one, premature rupture of membranes, still the same, PROM. Okay, the only thing is that we want, of course, because again, the amniotic sac or the amniotic bag is the one that protects the baby inside. So once you don't rupture that one, the baby is still intact inside. The baby is well protected. Once you rupture that one spontaneously or AROM or artificial rupture of membranes, the baby now is exposed to the external world. Okay? So that's one thing is that if the baby is exposed to the external world, the same is true with the mother. Okay? Therefore, usually what we do is that once there's this already rupture of membranes, the most important nursing intervention that you have to make is that frequently check for temperature. Because that's the only way you will know if the mother will be infected or not. So temperature, checking, monitoring right after rupture of membranes, whether it is spontaneous or AROM. Okay? So once you rupture that one, you take a look, of course, of the amniotic fluid. What's the color? Normally it is clear, isn't it? If it is yellow or green, it means only one thing. The baby has relaxed the anal opening. It pooped inside. Remember, we don't want the baby to poop inside the amniotic fluid. Why? Because the baby has the tendency, of course, for it to swallow it. If the baby swallow it it's fine. If it goes in the GI tract, it's fine. I'm fine with it. But the worst thing is that we also inhale it. If it goes in the lungs, it will gonna coat the opening, okay, the bronchioles, and it will gonna coat the alveoli. What will happen? The baby cannot breathe effectively. Okay? So it means only one thing if we have meconium stain or meconium aspiration. Fetal distress or fetal respiratory distress. Because it will stick in the lungs, inside of the lungs. It is very hard to clear. And the baby will gonna have a hard time breathing. Okay? So what is the most common result, of course, of the baby poop inside the inside, of course, the amniotic bag or inside, of course, the mother's womb? One important thing is that if they are receiving a decreased level of oxygen. Two reasons. Either the uterus is contracting or the placenta is old enough. It's not old enough, is too old to support the need of the baby. Just like if the baby is already post-mature. 42 weeks, the baby is not yet out, and the baby is still breathing through the placenta cannot support the oxygenation need of the baby. So again, because of course of decreased oxygen, the baby will relax his anal opening, anal sphincter, and poop inside. So if he poops inside while it's not coming out, he will gonna of course swallow and aspirate it. Okay? Mhm.
So what do they do to take it out? Like what kind of procedure?
Nothing. Support with oxygen. And make sure to support that the baby will gonna clear it out. There's no way, of course, we could clear it. Because it will gonna coat, of course, the ovula. The only way is that we try, of course, to support the respiratory function of the baby, just like suctioning the baby frequently. Another one, over oxygen. And the baby should be kept commonly in the neonatal ICU until numbers of oxygen were gonna go better. Just like the baby, of course, could breathe spontaneously without, and usually recovery for that one is quite delayed because, of course, of the fact that there's nothing we can do about it. Okay? And the baby could clear it out spontaneously, but it will take some time. And the only common downside for that one is that you just imagine if the baby, of course, sucked or inhaled a lot of it, how many percent, of course, of the total alveoli population, of course, are covered? So the more it is covered, the more that the baby is exposed, the more alveoli is covered, the more severe, of course, the respiratory distress. Okay? So the best thing for that one is that prevent it from occurring. What was the best way to prevent? Monitor the fetal heart tone. Any changes in the fetal heart tone signifies that the baby is in distress. We have to do something for the baby or to the woman in order to maintain the fetal heart rate between. Very good. Okay. By any chance, the fetal heart rate should never go down below. Very good. So remember that one. If you have a below 100, you are in deep trouble. Yes, question.
You said if the baby is a swallow, I understand. So amniotic fluid, if they swallow and drink.
Yeah, provided it's not stained, there's no poop.
Yeah.
They do, but we don't have any poop. Okay.
How about they inhale also then?
Yeah. If they swallow,
Amniotic fluid?
yeah, it is swallowed when the lungs is also full with the amniotic fluid. It goes in the lungs too. Remember, lung is not functional. So amniotic fluid, once they swallow it, of course it will gonna go there. The only thing for the lung fluid, it will be expirated because again, why? Why we release most, of course, of the lung fluid? It might be part amniotic fluid there. Because the baby is not functional. So the baby is nothing is preventing, of course, for the amniotic fluid to go inside the lungs. And the lungs itself is producing fluids. Okay? So we wanted that the amniotic fluid shouldn't be with no poop or meconium. Because again, we know that the amniotic fluid goes also to the lungs of the baby. They get it? Not only that they swallow it and they pee it or they poop it, and they don't poop. They pee it out. They also, of course, goes into the lungs because the lungs at the time the baby is inside is not functional. It does not expand. Therefore, amniotic fluid could freely go inside and out of the lungs.
So before that, they never poop inside,
No,
right?
we don't want them to poop because pooping, it means, of course, only one thing. The baby was subjected to fetal distress, just like decreased oxygen supply. That's only one thing, okay? So again, we don't want them to,
So 9 months they don't poop in there.
no, please, don't.
I'm just saying.
No,
I'm asking.
don't. I don't want the baby to poop. Because in the first place, do they have food in their GI tract to poop out that much? The one, of course, that they do is that the lining, of course, of the GI tract is developing. Plus, of course, the amniotic fluid that they swallow. That's the only thing, of course, that they more or less, they don't have any solid feeding at the time. So they don't poop. But there's a little bit of poop there that's accumulated. It's not that much. And that little poop, of course, inside, we don't want it to come out. Okay? And what else? That's meconium stain. What else? There's something, of course, to talk, of course, in my mind. But again, it will surface later. But again, that's basically, they swallow it, it goes, of course, in the lungs. The only problem for that one is that, as again, if there's meconium, it will gonna block the lungs. It's very hard to get rid. Because the fetal lung, when they will be coming out and they will be inflated, it's not yet strong enough to expel the things. And again, normally, why we want, of course, the baby to be delivered normal vaginal delivery? Remember, the head will be, of course, subjected to compression when they are delivering, where they will be extending. When the best thing, of course, is that the great difference between C-section and vaginal delivery is that vaginal delivery will be very good for the baby. Why? because there is chest compression. When the baby comes out of the mother's of course vagina, the baby's of course chest was subjected of course to compression. What is the best thing of course if there's of course pelvic compression of course of the chest of the baby, all the excess amniotic fluid that is inside the lungs is compressed out. That is why their breathing will be much better. As you can see, of course, in C-section, their lungs, when you deliver a baby through C-section, you have to suction and suction and suction a lot because there will be a lot, of course, of secretions because the lungs is full of fluids. And again, there's no way that they expel it, but for you to suction it when they come out because they come out through the belly. Okay? That's the great difference. So again, yellow and green equals meconium stain, meconium aspiration, cloudy amniotic fluid, then you go there, that is infection. Again, infection, usually if that will be the case, usually keep coming out, of course, from other part, of course, of the maternal side. Usually because, again, remember, mucus plug is so fixed enough that nothing could penetrate it, even sperm, even virus. Okay? So yellow indicate the fetus has passed meconium or stool while still in utero, which is a big because we don't want it to happen. Okay? We want it to pass within the first 24 hours of birth. White or cloudy, you have pus. Therefore, you have severe infection. So one way is that. The question will be, how would you know if the one that trickles, because of how would you know that, again, the bag of water is still intact or has broken? Okay? Because sometimes it will be a swoosh of water. It could be a trickle, tick, 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 of course, out, of course, of the amniotic fluid, but you have a leakage already. And again, like for example, we don't want the amniotic bag or the amniotic sac, of course, to rupture if it is not yet properly aged. Meaning to say, we don't want amniotic fluid or amniotic sac to be ruptured, to be open before reaching, of course, 37 weeks of pregnancy. Clear? Because the goal will be, of course, to deliver the baby in the full term as possible. Okay. So what if, oh, I have contractions. You said, of course, I got the bloody show before, of course, and I think there's somebody come out. So again, the only thing for that one is that sometimes because it's the bag of water, you cannot reach it yet, but you can feel, of course, that there might be bloody show. So the question will be, did the bag of water ruptured or not? That's the question. And if it is not yet fully dilated, we don't want to rupture the bag of water. It should be proper timing, okay? Here, you have, of course, the nitrogen strips. And the nitrogen strip, of course, will be yellow colored. So again, there's a difference, of course, of pH. Vagina is acidic in nature, clear. This is the normal pH of the vagina will be as low as 5, but commonly 5.5 will be good enough. But that's acidic. Amniotic fluid is alkalic in nature. Meaning to say, the pH level for that one, of course, will be, of course, above 7. 7 is neutral. A little bit above 7 will be alkalic in nature. Okay? So if the yellow strip turns into blue, it means that, yes, it answers your question. Yes, it is amniotic fluid. Therefore, your bag of water has already a leak or has already ruptured. Okay? But if it remains yellow, it means to say, of course, that no, the fluid there is of the vagina. Okay? The nitrogen strip only reacts if the pH level, of course, is above, of course, 7, which is, of course, alkalic in nature. Okay? So that's one thing, of course, usually be careful not to touch it, of course, to the outside of the vagina. So make sure, of course, to touch it, of course, on the wall of the vagina to make sure, of course, that you are testing the amniotic fluid. If there's no amniotic fluid there, for sure, there's no changes with the yellow strip. It remains yellow. So if it is yellow, you say, oh, thank God, we still have an intact bag of water or intact amniotic sac. Because why? Why want it intact? Because if the baby is not yet fully ready to come out, we need the baby to be closed as possible. Because we don't want any possible infection accessing the baby. And one way to do that one is that by breaking the bag of water. So if the bag of water is open, so that we have to institute, of course, precautions measures. One of the precaution measures will be to check the temperature of the woman frequently to make sure, of course, that the woman is not having a form of infection. Yes, the question.
Yeah, sometimes some people get labor and deliver baby by 7 months or 8 months. Why it happens?
I don't know. Probably the husband is having frequent sex, of course, with the woman. No, that's the thing. Because again, this is a theory. So what causes it? It could be injury. It could be what initiates, of course, through labor. Because through labor, of course, It could be trauma will be, I would agree with trauma, especially if trauma, of course, that injures, of course, the cervix, that open the cervix. There's no way, of course, of going back. Other things, I don't know, because the theory itself, of course, of when is the woman will gonna be having true labors. Is still a question right now cannot be answered. There are some theories that we're gonna present when is the woman doing labor. Frequency, usually we want it, usually the frequency occurs will be 40 weeks from the date, of course, of the LMP. But commonly, when is the woman, of course, will give birth, we don't know. Theory-wise will be probably, of course, the release of hormones. But what primarily control hormones? It might be, of course, the one that control hormones during the entire pregnancy will be the placenta. So if the placenta probably is old enough, said, oh gosh, I'm so tired already, I'm so old enough, I retire, I resign. So the placenta, we're going to stop producing progesterone, sudden drop of progesterone. Now the woman is now ready, of course, to give birth. But in any chance when, what causes, of course, the woman to go into labor, besides trauma, okay, that goes into it, there will be a lot, of course, other things, but we don't know specific. Because the baby, the uterus, again, even oxytocin, even if you give, of course, a woman oxytocin injection, if the uterus is relaxed, the uterus will respond to that one. There should be conditioning first, okay? That there is, of course, initiation of labor, that there is, of course, the shift of labor, and then, of course, the uterus will be contracting before you could help, of course, the uterus to progress with its labor. But when does it start? The question is, I don't know. It might be the structure of course, the cervix. It might be, of course, the structure, of course, of the baby inside. It could affect. There will be a lot of factors, but when, even doctors doesn't know. Okay, so again, when they rupture the membranes, what is the time, method of rupture? Does it rupture alone? If you see, of course, that it ruptured already, and then without any intervention, that will be, of course, your SROM, spontaneous rupture of membrane. If you inserted a new hook, okay, and ruptured it, we call it one. And what is the color of the fluid? So is it clear? Okay. The worst thing, of course, is that when you rupture, there's a lot, of course, of the experience for that one. When I rupture it down, it's very, very cloudy. Not only cloudy, it smells a rotten fish. Gosh, that's one of the worst, of course, delivery. I'm just holding myself, of course, to puke during the delivery of mine. Okay, and then pray, huh? Because the woman is having sexually transmitted infection. It was not managed properly. Okay, it ascended, it even infiltrated. So again, STS could be going and other things. And it is a massive infection. The color is so turbid. When we speak of turbid, it's so cloudy. And once it ruptured, the smell, of course, I'm not saying, of course, the smell, of course, of that one will be sweet, but it's salty, a little bit salty, but it's just like, of course, a rotten egg broken. If you see that one, it's so foul. So I have to contain myself to make sure, of course, that the baby is still alive until, of course, it comes out. It comes out, of course, that the baby is safe. So that was the time, of course, that I said, right away, I clean the baby, because I have to, usually, of course, I have to clean the baby. Once I clean the baby, the first thing I did, of course, before weighing the baby is put terramycin into the eyes, because I don't want the baby to be blind or the eyes to be infected. Because this is standard care, but I give priority to that one. Before weighing the baby, okay, right away, usually what we do is that when you do care, usually here, of course, with the baby, in the old books, in the conventional type, we do shower the baby. We clean the head, because again, there's a lot, of course, of fragments there. So it's just like things. So we have to clean it up, and we shampoo the baby with Johnson's & Johnson's. Okay? No tears. Usually we do that one and clean the baby out, but later on with the new text, those, of course, the things, of course, the cheesy things, of course, umbilical Barton's gel is fine. The cheesy things, of course, around it, we don't remove that one actually here, because it will gonna help the baby transition towards the temperature outside. So we have a new text, of course, here. We don't totally clean the baby. The most important thing is that we have to wrap the baby to stabilize the temperature. That's it. We don't shower. We don't, here in America, we don't of course, do the baby. We don't clean them. Just clean the gauze, of course, change, of course, the liner, and then put, of course, the baby there and make sure, of course, the baby warm. That's why, to keep, of course, the baby open, usually we have a radiant warmer right away to receive the baby, so that, again, we can keep the baby open. If you don't have radiant warmer, you have to pack the baby right away. And one way to do that, remove, of course, the wet things around the baby and pack the baby right away, or else the baby will lose a lot, of course, of temperature. Okay? Okay? So one thing is that primary gravida, average length of labor, 8 to 18 hours. It could extend to 3 days. That's only stage 1. In multigravida, 1 to 14 hours or less than an hour, just like baby is out. But again, we don't want it to happen because again, of possible injury to the baby. Stage 1, we said dilation. So again, when is the stage 1? There are 3 phases, 4 stages. The first stage is dilation. So again, when is until when? So stage 1 for me, and for the book and most text, will be from the start of true labor. What is my definition of start of true labor? Any contraction that results to cervical change. Okay? Until full dilation. What is full dilation? 10 cm, 100% effacement. Okay? That is the stage 1. And stage 2 will be expulsion. The delivery, of course, of the entire baby. Usually, we want it to be head first. Okay? And stage 3 will be the placenta. And stage 4 will be recovery, the mother. First one, of course, we start with dilation, latent, active, and transitional phase. And usually before, common is that, the more common mantra, no food to the woman in the active phase of labor. When is the woman in latent phase? When, of course, is the woman in the active phase of labor? When is the woman transitional phase? Okay? Oh gosh, I don't have the phases. But the only thing I know is that latent. Mr. Jones, what should I do to know the stages, of course, of dilation? What should I know? What would I do? What is the doctor or the assessor or the nurse do in order to assess which phase of the dilation is the woman is? Use your 2 fingers. We call it one assure. Always remember, you put gloves when you do that one. Sterile one. That's why we call that one SBE. But again, one thing I would like to remind everybody, never insert your 2 goddamn fingers when the woman has blood in the vagina. If there is, of course, blood that's streaking out of it, never use your 2 fingers. Assess first. Commonly, of course, we have to do ultrasound first to the woman because we don't want to touch, of course, placenta previa because it will gonna cause severe bleeding and it will gonna cause spontaneous delivery and we don't want to deliver the placenta first. Clear? By any chance, even if it's total placenta previa, we still want to be the baby out first. Okay? So there's only one way to do the slice the belly, remove the baby out, and remove the placenta out. If you need, of course, to cut out the uterus. That's the only way in order to both have to save, of course, the baby and the mother. Cut out the uterus because, again, why do I need, of course, to cut out the uterus in placenta previa? Remember that one? Capture me because I received one. Because, again, most common placenta previa, their chances of bleeding is very, very high because, again, what's the reason? Because the segment of the low segment of the course of the placenta, of the uterus, is not, the muscles is not thick enough. It cannot close the bleeders. Because of that one, the most common reason, of course, the most common thing we do in order to save the woman from hemorrhage is to cut the entire uterus. Hysterectomy, right after C-section. The woman then repair, of course, the C-section, return the woman, keep the vagina so that again the husband could still be happy. But you remove the uterus, so goodbye, of course, childbearing. So is the one can be pregnant without the uterus? Of course not.
No.
But the only thing is that did you save the woman?
Yeah.
Yes, because if not, the woman could die with bleeding. And there is no goddamn way you can prevent, of course, the woman from dying. Only one thing, remove that goddamn uterus and of course, tighten, of course. That's the hardest part, of course, of the thing, of that complication that shall we do. But if the doctor will going to try to challenge, they could, of course, remove the placenta and try, of course, to make sure that it will going to stop bleeding. Or any hemostatic intervention. When we speak of hemostatic intervention, we stop the bleeding. It could be inverted. But some doctors, they don't want, of course, to outweigh the risk because the risk is too goddamn high. I'm sorry, why I'm use the goddamn, but it's too high. Therefore, because of that one, usually they have to make, of course, a crucial decision, especially the woman. Are you willing? And usually, who will gonna be saying no if we're gonna save you, isn't it? So latent, so insert your finger. How would you know it's latent phase? Distillation. The most common thing, of course, I do is that I insert the tip of my finger. I don't use this one, huh? This is just a crooked finger. This is supportive finger of mine. This is the primary manipulating finger of mine. Okay? What I do is I've inserted, I put, of course, the tip, of course, my fingertip, not the nails. The fingertip, I palpate it. Could the tip of my finger insert in the hole of the cervix? It means to say, of course, that it is 2 cm. 1 to 2 cm. Okay? until if I insert, of course, the full of my finger, and if I can accommodate, of course, the width of my 2 fingers, that's, of course, still latent phase. 1 to 4 cm. Clear? That's the thing, of course, I do, of course, before. That's the most common one. But again, technically, 1 to 4 cm is latent. Meaning to say, yes, we have true labor already. Once I can spread, of course, my finger already. That will be above 4. Okay? So it will be 4 to 8. So meaning to say, the woman is now in the active phase of labor. Okay? Once I spread my fingers, and again, barely I could touch, of course, the edge. If I'm going to stretch, of course, my fingers, that is a full dilation to me. That's usually, of course, the woman in the transitional phase. Meaning to say, the dilation will be, of course, around 8 to 10 cm. Once I can feel the entirety of the head, of course, of the baby already. So you have to turn your fingers to the baby. The woman is now ready for delivery because that's already 10. But what I'm saying, of course, is that in the transitional phase, before I allow the woman, to suggest the woman, of course, to bear down, to push, okay? And again, when we speak, push as if you are moving your bowels, okay? So commonly close your glottis. So some women say, that one. They do that one, and that is not an effective one, okay? So you have, of course, to bear down in a closed glottis. We call that one vasovagal stimulation, okay? So when you do that one is that, just bear down, push as if you are pushing your bowel movement. That's the best way to coach a woman on the transitional phase, okay? But, again, if it is 10 cm, another thing you have to check is that, do you still have a lip? Meaning to say, usually at 10 cm, we still have already 100% effacement. Meaning to say, we don't have a lip. So it's thin as paper already on the sides. So as a matter of fact, 100% you cannot feel any more, of course, the cervix. It is just one whole great canal directly when you insert the finger. Okay, no lip anymore. What you feel, of course, is only the fetal head. You don't see, of course, a folds that stretches, of course, when you feel it with the entire baby. You don't have os anymore, even how tiny. Okay? So if there's is with 100% effacement, now you can start, of course, the woman to bear down because the woman now, of course, has ended the dilation. The woman now is ready at the start, of course, of expulsion, which is stage 2. Expulsion will be full dilation and full effacement. Okay? No lip, 10 cm. And the woman now will be guided, of course, coach, of course, to push down and bear down until the baby will be coming out. And the process of baby, of course, coming out will be, of course, the next stage. Okay? Dilation, effacement, and dilation, of course, will be 2 important things. I'm going to repeat myself. So again, 10 cm, 100%. So how would you know 100%? So my definition for that is that no more lip. Okay? It's a continuous canal. You cannot feel anything. That constricts, of course, at one. So expulsion will be crowning. So crowning, what station?
2.
Huh?
Station.
What station, of course, if we are in the crowning stage? Huh? Crowning will be, you can see, of course, the fetal head out of the vagina. You don't need, of course, to insert your fingers. Okay, that's crowning. Okay? The presenting part. Usually, of course, it will be around stage 3. In stage 4, the fetal head is ready to come out. But if you still, of course, feel, of course, the head, of course, you cannot see it, but you have to insert you can do SVE to feel it. It's not yet total crowning. But crowning will be, top of fetal head appears in the vagina. In the vagina has to split. It will be tearing if you don't tear it to cut it. Okay? And we don't want any jagged tear of the vagina. Okay?
So do you have to always cut it?
Commonly we do. Usually we do. Because with me, in my experience, in my concept, of course, of delivery, I would rather cut it. But there's a lot, of course, of thoughts with that one.
Even if you have like your 5th child or whatever, you still have to cut it?
The question will be, what's the gap?
How long the baby deliver, right?
No. That was the gap, of course, from one pregnancy to another pregnancy. This is very important. The longer, of course, the gap, the longer than 2 years, usually we do. But if it is of course around just 2 years and it's primipara, I could ready that one. But I have my own tricks anymore because I could manipulate it. I have to see, of course, the fetal head in the full crowning. If I can see, of course, that in the full crowning, I can see more than 50% of the occiput. okay, or all of it at one, the best thing I could do, of course, is that support the perineal muscle. So I have to put the pressure. I have, of course, a saddle gauze. So I deliver, of course, the fetal head. I tell the mother, push, push, push. But I put a pressure on, of course, on the perineum. The perineum, of course, when you speak, of course, of the perineum, that is, of course, the muscle or the lining in between the bottom, of course, of the vagina, closer towards, of course, the rectum.
Okay.
I have to push a pressure there and pinch there to prevent tearing, because that's usually, of course, the area of tearing. And again, the worst thing that will going to happen will be tearing through and through the vagina and the rectum. It will take forever to heal. It will be a big inconvenience, especially for the husband. So normally, you teach them, if you teach them, if it is for you, I would suggest for you men, forget about it. I'm gonna suture it. Just tell me how tight I will gonna suture. But it's not a recommendation. But usually, healthy-wise, the risk will be high, with my perspective. But there are some doctors who don't want, of course, to cut. If they tear, they allow them to tear. But my question always will be is that you don't know the force of the mother when the mother is pushing out. It might be so tough, and again, the expulsion will be so speedy or so fast that it will gonna tear through and through. My biggest, of course, that's why in my world of delivery, my experience of delivery, I never experienced, of course, a through and through tear. Because if you were gonna do that, because you know what, the pressure on the pressure, of course, in the perineal muscle, I got it only for the one. Even the woman didn't know how to read. She is a cultural midwife from my locality, and she taught me. That's the first exposure I got for the delivery. And she would say, come on, you would like, of course, to watch. I'm already first year or going second year in nursing. And she tagged all along with me because she's my relative. She wanted me to understand because I'm already in nursing school. So that. And she taught me how to do that. So I said, sometimes I don't, especially if the second delivery. But she told me, you have to put a pressure in the perineum. Or else, once the woman will going to be pushing out, you could have a tear. And the biggest tear we're going to do is the through and through the rectum. Do you get it? So again, there are factors. So how is the woman practicing Kegels exercises in between the delivery? That's an important thing. And what is the gap? If it is already 8 years, the vaginal muscle, of course, is like a primary again. Okay? So that's one thing.
One last question. If you're going to cut, when are you going to cut it?
Full dilation.
Okay.
So the only thing is that, what I do, of course, is that, insert this one, okay? If the woman, because the fetal is protruding already, isn't it? If, now, the vagina, I don't need, of course, to insert my finger anymore. It's full crowning, isn't it? When it's full crowning, you can see the fetal head anymore, even I don't touch, of course, the vagina. So what I do, of course, is that, the vagina will stretch. It is just one big hole you can see there, okay? It's in your picture. So what I do is that, I use, of course, my other finger. Because I'm right-handed, what I do, of course, is that I insert my two fingers. Remember, you have, of course, to insert this one on the lip, of course, of the vagina itself. Again, one way to do that one, because I don't want to push my scissors. The scissors that we use, of course, is your bandage scissor. Wherein there's a guide on the other side. Okay? And the other one, of course, the blade will be on the other side. Okay? So what we do is that we insert, of course, our two fingers to do episiotomy, because in my country of origin, we are allowed to. Here in the United States of America, you are not allowed to. You have, of course, to take your BSN. You have to be a CNM in order to do that. Okay? But what we do, of course, is that I insert usually my left hand, gloved hand, in between the fetal head and the vagina. And then if I know, of course, that I have, of course, full crowning, almost 50% of the fetal head will be protruding, the occiput is already down out there, that will be the time I have to cut. So when do I cut? When do I cut? The question will be stage 4, full crowning, before the baby comes out. I tear that one, cut it, and use my favorite, of course, my favorite will be, I can only cut medial, 6 o'clock or 7 o'clock. Okay? I cannot cut, of course, because it will be awkward for me to cut, of course, on the 5 o'clock. So it should be, of course, median or mediolateral. Mediolateral will be, again, the vagina is, of course, served as a clock. Okay? So when you speak, of course, of a clock, usually, of course, the cut that is recommended will be median. So a median cut of your episiotomy will be 6 o'clock. And then usually what I do, of course, I can do 6 or I can do 7. But I cannot do, of course, the 5. Okay? So this one we do. On a full dilation. Not only full dilation, peak of crowning. Okay? So before the baby's head will be coming out. Because again, remember, the occiput is elongated. The biggest part of the cranial, this one, the biggest part, of course, of the baby will be this dimension. because this one will be protruding, elongated, the baby has to pass this area. And this is the biggest, of course, dimension of the fetal head. Okay? That's why occipital frontal circumference is very, very big. So before, that's why my gauge will be, once, again, the occiput is fully exposed, okay, that's the time I cut, to allow, of course, the biggest part of the head to pass through. Because you have to be careful, because again, it will just, if you don't, it's spontaneous, because again, if you don't do that one, it will gonna tear by itself, especially priming. So that's why a joke. That's why usually, of course, a joke before is that, Doc, when you suture my wife's pichotomy, make sure, of course, you don't forget to leave me a hole. It's enough hole, okay? Or else, of course, it will be the end of the world to me, okay? So that's one thing we will do. But again, there are some group of doctors that have said that they don't believe in such. They want to allow tearing. The worst thing about tearing is that it is very hard to repair. If you cut it with a scissor, it is a straight cut. Therefore, if you were going to suture it later, because again, in country of origin, we're the one who's doing suture about the pichotomy. We call that one the pichorrhaphy. Okay? So it is easier for you to suture. In the healing process is way much better a cut with a scissor than that nature cut, which is sometimes zigzag, jagged. It's very hard, of course, to repair. It's usually, of course, delayed healing. So what I've said is that it will take more than 6 weeks. That's why my mantra will be for the husband, excuse me, your wife delivered a baby, no sex for 6 weeks. Okay, clear? No sex for 6 weeks. Okay? Because why? You have to allow proper involution. And the total involution process is 6 weeks. Okay? Therefore, even, of course, you are craving, of course, to do so, of course, to your wife, forget about it. Express yourself. Sing the song. All by myself. No, that's supposed to be a joke, okay? But again, there are a lot of expression, but again, to prevent, of course, to save, of course, the woman's health, okay? Stage 3, that's stage 2, until, of course, you deliver the baby. And the delivery, of course, of the baby will be, as I have said, presenting part normally will be the fetal head. And then, the baby will going to extend, of course, its neck to allow the delivery of the entire head, okay? And once the fetal head will be outside, the baby will going to turn towards the side. Commonly, of course, the baby will going to turn, of course, I don't know, but commonly, of course, the baby will going to turn, of course, to his left. Do that one, deliver, of course, the anterior shoulder, deliver the posterior shoulder, and then the baby will going to turn around. And then the baby will be delivered, of course, in a supine position. Mm-hmm. You can see that one on YouTube, isn't it? Okay. So primary, stage 3, 30 minutes. So again, usually 25 to 30 minutes in placenta delivery. So if the placenta was not delivered after 30 minutes after the baby is delivered. So again, stage 3 is when? Total expulsion of the baby until total expulsion of the placenta. That is your stage 3. Okay? That's the technical term definition, of course, of the stage 3. So in primary gravida, it will be 30 minutes. So usually around 20, depending, of course, of your maneuver. Okay? In multigravida, 5 to 15 minutes. Okay? Now, the question will be is that, how would you know that your placenta is now separating from the uterus? How would you know? Now, you are the one giving the delivery, and you are assisting, of course, the doctor. Now the baby is out. You suction the baby. When the baby's head, of course, comes out, the baby is just like a cat, okay? And then, because of that one, usually common is that the baby is delivered, okay? Now, the clamp, Kelly, forceps, and then usually, of course, here in America, you allow, of course, the father, if there's the father, of course, to cut the cord, okay? Okay, so I have one child, of course, was born here in the States, so and then the nurse, of course, said, no, I have to do the video for this one, so just cut it yourself. So bad me, okay? So because the father is invited, would you like, of course, to cut, of course, the cord? Once it is cut, another nurse will be, of course, the one taking care of the baby under the radiant warmer. Everything, measurement, everything, of course, all this intervention, okay? So and now, if you are the primary nurse assisting, of course, the OB, your goal will be to make sure that the placenta is delivered, because your after delivery of the baby, it's not yet the end of the world. You still have work to do, okay? So usually, you handle the other forceps, because there are 2 clamps. The other Kelly will be, of course, to the baby, and the other Kelly will be attached, of course, to the remainder of the umbilical cord that's attached, of course, to the woman's vagina still inside, okay? So you have to know, sometimes, During old school, we are taught, of course, to do, of course, tag it along, put a little bit, of course, of tagging pressure to the placenta to enhance separation. We want to make sure that we have a healthy placental separation. Okay? So usually during my student days, and when I was doing, of course, still delivery way back home, I usually put a pressure. I do down, up, just like doing a beat. Right, left, up, down. Okay? Until I feel, of course, the pressure. I feel, of course, I see the signs that the placenta has separated. What are those? What are those? Okay? What are the signs of placental separation in your book? First one. Okay? Did you see it there? First one, the uterus has to contract. Okay? First one is that the uterus becomes firm and globular. Yes. Firm and it's become round. It's just like a grapefruit. Okay? First one, it will gonna contract in order to expel it. Okay? It will rise. It will be rise in the abdomen. The uterus, of course, will be rise in the abdomen. Okay? And you can see, of course, that you feel, of course, when you put pressure of the cord. Oh, you feel, of course, that it released the pressure. The cord lengthens out. So first one is that the uterus becomes firm and globular. Number one. Number two. Okay? The uterus rises to the abdomen. It went up. Okay? Another one. Lengthening of the cord. The cord lengthens outside that one doing the vagina. And again, the last and the fourth sign will be the sudden gush of blood. Okay, the sudden gush of blood, it means to say that the placenta now is separated from the endometrium. Now, your goal will be, the documentation will be, document what kind of course of side did you, of course, deliver it out. Okay? First one is that, in the fetal side, you can see it's clean, just like, of course, a mushroom with a hook for that one before, just like a cauliflower. Upside down, the cord, and it is shiny. It's clean. Okay? It's a membranous layer of the amnion layer. Okay? So we call that one shiny Schultz. And mostly, the healthiest way, of course, to deliver a placenta will be shiny Schultz. Schultz mechanism. So if you're documenting, placenta is delivered at this time. Okay? And again, what method or what percentage or what mechanism? It should be shiny Schultz. Meaning to say that it is the fetal side that pulled out first. So again, the maternal side is enclosed, of course, inside out. Okay? Just like an outside umbrella. Yes?
I was reading about hemorrhaging. So how do you know when they start to hemorrhage?
Okay, hold on. We're not yet, I'm just letting you know, of course, what is placental delivery. So later on we will know. Okay? So first one is shiny Schultz. Now, the first one is that you see, of course, that it's like, of course, an open cauliflower. Cauliflower now, of course, that is the jagged edges, of course, there. You can see this, like, of course, meat, like that one. If it is so dirty, we call that one dirty Doncas. And if it is the maternal side, because that is, of course, the placental side or the amnion side, the chorion side that is implanted in the endometrium. Okay? Maternal side, rougher and irregular. This is the risk now. If it is, of course, Duncan's mechanism, the risk for bleeding is very high. Okay? So commonly, we need, of course, to know. So again, once it is delivered, but the risk of bleeding is high. Now, you don't throw away, of course, the placenta. You check the placenta, check it out, make sure, of course, that complete. My old way, of course, of doing it is commonly with Schultz. The membrane, of course, of the Schultz, of course, will be, I'm going to grab it with, of course, or glove hands, stretch it out. If it cover itself, I could cover the entire placenta. If I could cover it, and then when you spread out the placenta, you see there's some lobes. If all the lobes are present, I can see, of course, I can document that is completed. Check if there's no absent lobes. If there's the lobes, of course, if I spread, of course, in the drain, in the paper drain, of course, that one, and I see that there's no lobes, I'm gonna pull out, of course, the amnion side, and try to cover it. If I could approximate it, if it could cover the entirety of the placenta, it means that the placenta is complete. Okay. If it is a Duncan side, there's no way you could do that one. Okay. But again, make sure, of course, that it is, of course, completed. There's no lobes that's present. So now document, of course, what mechanism, Duncans or shiny or Schultz. So again, shiny Schultz or dirty Duncans. Now another thing for that one is that sometimes the doctor will, of course, insert, of course, a finger and remove, of course, blood clots inside. Okay? So you will know, of course, that the bleeding will be if it is profuse. Okay? One way, of course, to check for the bleeding, of course, if the bleeding will be, the risk of bleeding will be one thing. Dirty Duncans, and make sure that your goal there, once the placenta is delivered, make sure the uterus is contracting. That is your goal. Keep a contracted uterus. Meaning to say you have to palpate frequently the uterus, of course, to make sure that it's contracted. A baggy uterus, it means to say it has to relax. It's not contracting. It is a risk for bleeding. Okay? How would you know that the bleeding, of course, you risk the hemorrhage, of course, do not exceed the normal blood loss of childbirth. The normal childbirth blood loss will be only between 300 to 350. If you are more than 500 to 1,000 already, that is hemorrhage. There's something you have to do. And the most common reason why the woman will bleed after delivery is a retained placental fragment. That's why I would like, of course, to emphasize, of course, conceptually and in practice. That's what usually, of course, I do make sure, of course, that my placenta is complete. Because, like, for example, in my scenario, if I'm delivering it in the community, in rural communities, if I cannot remove, of course, the placental fragments, of course, shall we say, I deliver the baby, I put already the pad, I put the sanitary belts, or shall we say, sanitary pads, of course, to the woman, and the woman said, you know what, it's profuse. I don't doubt anywhere to the woman, I have to send the woman, of course, to the hospital. Because again, the woman would bleed to death if you don't remove that fragment inside. Because remember, it is a foreign object from the inside of the uterus. The uterus has there's only one goal, to expel it out. If it is not expelled, the uterus will gonna bleed and bleed, and the uterus cannot close, of course, its membranes. Okay? So the only way, of course, to remove it, its placental fragments will be to scrape it out. That's why the woman should go to OR to undergo D&C, dilation and curettage. So we have to scrape it inside. Clear? That's the only way to remove it. By any chance, we don't want any fragments from there. Postpartum death cause will be by hemorrhage, secondary to retained placental fragments. Yeah? It will gonna kill the woman. So stage 4 will be first of course 1 to 4 hours after expulsion. So usually the reproductive organ begins the total evolution about takes 6 weeks. That's why I said no sex for 6. But sometimes the husband, of course, will be asking, honey, it's been 3 weeks already. Holy crap. And there's a joke for that one. And we have a friend, okay? And you know what? The guy is a lawyer, okay? The guy is a lawyer, of course, and then of course the wife, of course, the wife is of course an educator, okay? So the wife is a teacher. And the OB that delivered, of course, their first baby is a friend, okay? Is a friend still. And again, believe it or not, when the woman was discharged, 3 weeks after, the woman has to go back to ER. The problem is not, but it's vaginal bleeding, okay? So again, here comes the OBC, so because she told them, why I have to wait for 3 weeks, of course, and then you have the bleeding. Is there placental fragment? The friend that's OB is so nervous, is so anxious, of course. What the heck that caused, of course, the bleeding? Okay? So she was so scared because again, she might assess it differently that now it remained bleeding because again, the presentation, of course, in the ER will be vaginal bleeding. So the most common thing, the first thing is that, how come? The lochia progressed beautifully. Why is it in the 3rd week, of course, the woman is bleeding? And when, of course, the OB check, of course, on the woman, she can see, of course, the laceration. And then she called the husband. God damn you, why did you touch her, of course, as early as 3 months? It is the husband who caused, of course, the vaginal bleeding. Because the husband penetrated. And then that's why the lawyer, of course, was so embarrassed, of course, with the friend is OB again. And then he reasoned out, you know what, doctor, I'm so sorry. I did that one. It's supposed to be done, but I can't contain myself. I'm so in love with my wife. But that's not the reason. But imagine, that's why no sex for 6 weeks. To complete the evolution. Although I know healing, of course, of the tissue, especially if the sutured episiotomy, will take only 14 to 21 days. But again, the inside, of course, of the endometrium takes, of course, 6 weeks in order for the woman to go back to the pre-pregnant state. Okay? Until such time. Because why? Here the doctor will tell you, okay, the baby will be coming back, of course, the first month, of course, to receive the hepatitis B vaccine. But the woman say, okay, come back to me here, of course, after 6 weeks. Until then, no sex. Okay? So the woman knows. But you know what? What can, of course, the woman know, of course, if the husband is so passionate, isn't it? But usually that's the one, because again, why we don't want pregnancy right away. Depending, of course, on the decision of the mother, is the mother breastfeeding or the mother is not. Because again, the first 6 months, of course, we don't want the woman to be pregnant during the time period. Because a woman could be pregnant right away, especially if the woman is not lactating, meaning to say is not breastfeeding. Okay? So if the woman will be pregnant, let the woman be pregnant after 6 weeks at least to allow complete recovery of the uterus, or else you put the next pregnancy at risk. Okay? So another one, of course, for that one is that to give, of course, sometimes of course, to the baby, the first baby, usually the doctor will recommend is that 6 weeks, after 6 weeks, the first visit, of course, of the mother, usually the doctor will gonna give methods of contraception. What will that be? Until such time, okay, the woman is allowed, of course, to have sex, of course, with the husband. Whoever that will be, it will be the boyfriend, I don't care. Okay, but who will be father of that? If it's a lot, of course, of fathers or a lot, of course, of husbands, it's fine. But again, until 6 weeks. Okay? So stage 4 will be hemorrhage, of course, and all these times, of course, watch out for hemorrhage, which is the number of problem, urinary retentions, which we're gonna talk after, of course, the break. Okay? You go on your break, and then, of course, we're gonna come back, of course, to continue, of course, the discussion. Oh, fair enough, 50, 100%. I can finish it. Now my question will be, after the corpus luteum, what controls the hormones? Or what produces the hormones of pregnancy? And when we speak of hormones of pregnancy, again, number 1 will be your progesterone, isn't it? There is some estrogen, but usually the rapid decline of progesterone will be hallmarking the labor. But besides that one, we have also your first one, human chorionic gonadotropin on the first trimester. After that one, it will be maintained by, of course, your human placental lactogen. What is the organ that produces, of course, the hormone? What is the name of the hormones again, besides progesterone and estrogen?
Estrogen.
What is the first hormone that will rise during pregnancy?
Right.
HCG, human chorionic gonadotropin. What produces, of course, human chorionic gonadotropin?
Chlorons.
What makes out of chorion later?
That's placenta.
So what produces HPL on the second trimester? HCG will rise only in the first trimester, remember that, to make sure that there will be implantation, okay, in the development of placenta. In the second trimester, onwards, what is the most important hormone that controls, of course, the metabolism of the mother? Human placental lactogen. Lactogen is the hormone. What produces it? Placenta. Just imagine, you release the placenta, you expel the placenta, the woman now is suffering from the decline of hormones, HPL and progesterone. Clear? So the woman will be, of course, hypotensive, that's one, of course, and hypothermic. That's why the woman, of course, who gave birth during this period, once we clean the woman, we pack the woman, and usually we cover the woman and make sure that the woman is warm. Just imagine if it is a primary, I'm thinking of a primary woman, okay, which usually labors, of course, for at least 18 hours or 14 to 18 hours, okay? Depending on the practice. That's why when the woman is in labor, besides, of course, the active labor, I want my pregnant woman, my laboring woman, as much as possible if she could walk. Because if she could walk, and then they will start to don't bear, just pant. You can see, of course, because before we have a labor room, so allow my women, of course, pregnant women to walk. Okay, they walk and smiling, of course. And then if they will be contracting, they were going to hold, of course, on the wall, panting like that one, because I don't want them to bear. And again, and because of that one, progression of labor is way much better. I observe personally, of course, is way better if they ambulate. And the great difference of false labor and true labor will be a woman who is having true labor, when they ambulate, they have to stop because they cannot walk with true labor. But if there's a false labor, when they walk and rest, it's going away, but not with true labor, because the intensity of the duration will be increasing if the woman is walking. Okay? So don't make the woman carry, of course, a big can, of course, of water, of course, on their head, of course, while they are in the active phase. Don't do that, but let them ambulate, because ambulation enhances progression of labor. But there are some doctors, the baby, the women. Okay, but it's only when lie in bed. Okay, lie in bed. That's why the woman has cramps. Okay, so I don't like that one. I prefer, of course, ambulation up and about until, of course, full dilation. When they are full dilation, then, of course, we put them in bed and spread the legs, put the syrup, and now they are ready for delivery. Okay? And undesirable effects of anesthesia. One of the effects of anesthesia is hypotension. Watch out for that one. Because, again, anesthetics is a CNS depressant. It will going to depress, of course, your medulla. The medulla, the part of the brain that controls the three major things, basic function of the human body. Okay? One will be heart rate. We call that one cardiac rate is centered in the medulla. Another one is respiratory centers. Therefore, it controls, of course, the rate of the respiration. Another one is the vasomotor center, which control the diameter of your blood vessels. If it is, of course, dilated, blood pressure is low. It is constricted, blood pressure is high. Okay? So there are three centers. That's one of the target effect, of course, of anesthetics. That's why I monitor, of course, the woman. Another one is that right away, before, of course, bringing and cleaning the woman, you have already exposed, of course, the woman to the baby, so to enhance bonding. And later on, when the woman is rested and the baby is stable, so we call that phase, of course, rooming in. So we're gonna room in the baby from the mother from the baby, of course, from the neonatal unit, of course, towards the mother. Okay. So nursing care. So always remember during stage 1, these are the things, isn't it? Vital signs, contraction, because we are monitoring. Again, what are the things in the contraction that we are monitoring? First one will be interval. First place, this is, of course, assessment during, of course, stage 1. What is stage 1? What is dilation, isn't it? So again, the question will be, which stage are we? Okay? What are the things that we have to monitor? Usually, basically, duration, interval, isn't that? Intensity. Okay? So that's one thing. But the bottom line, the most important thing is that that's only for the mother. How about for the baby? The most important monitoring here, of course, is your fetal well-being. How do you monitor fetal well-being? Because you don't see the baby.
Heart rate.
Very good. Fetal heart rate. Okay? So physical and emotional support to the woman. So again, the woman could be usually in the stage 1, even if the woman is in latent phase, some doctor allow them to go home. Okay? Until it progresses, of course, to the active phase. Okay? We want the woman to go in the hospital if you want it, because it is too long to wait for a woman. If the woman, I want the woman to go to me in the labor unit, of course, if she's already around 8. Okay? Because at around 8, I will just adjust a little bit, of course, and then deliver the baby. Okay? And believe it or not, I was during the time, of course, because usually, of course, when I do the delivery, the entire night, boom, 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 back to back, we have 1, 2, 3. We have a labor room. How many beds are our labor room? 1, 2, 3, 4, 5, 6, 7, 8, 9, 12. 1, 2, 3. 12 beds in the labor room, and then 1, 2, 3, 4, 5, 6. 6 delivery table. Because before, we separate the labor room from the delivery table. Okay? So once they are already 8 cm, we mount them on the delivery table, and then we deliver, of course, the baby. The entire night, the highest we could, of course, is that we delivered, of course, I think 8 babies. In one whole night. So back to back, boom, 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 boom. Just like the women are laying eggs. That was because why I was exposed, of course, in a government hospital during, of course, my and remember, that's why I was so happy. Just what I remember, I cannot graduate. I cannot take my boards unless I delivered 15 babies. Okay, all of us, if we graduated on that school, okay, at one time. We graduated 150, okay? 150 of us. So just imagine how many babies are delivered. Okay? Not only that one, that's only for one school. In our locality, we have, of course, I think 6 universities offers nursing. So we have to compete from each other, okay? Sometimes we go to the mountainous areas just to look for deliveries because we need, of course, documented one. In order to comply. Some of our classmates, of course, who graduated, but they cannot take the boards. They have to complete the requirements. See? Okay. So ADD? Anybody knows how to compute ADD? Anybody who knows how to compute ADD? Or the question will be, anybody who doesn't know how to compute ADD? Yeah. So what is the data that we need? What is the data that we need to compute the ADD? First day of the last menstruation, we call that one a short LMP, last menstrual period. Okay? Okay. So how do we compute? Based on Nagel's rule? Minus 3 months plus 7 days. Okay? If you need to move 1 year, then move 1 year. Okay. So preterms will be, of course, preterm special precaution taken because preterm babies, of course, are those who are born when? Before completing the 37 weeks. Okay? So they should complete. I want, of course, the completion because, again, Mr. Leo, if you will round off, of course, 36 weeks, of course, and 6 over 7 days, okay? It's almost 37 weeks. Is it, of course, still premature? Yes, indeed. So I would like to clarify myself. If the baby is born even 36 weeks, 6 days, and 23 hours and 59 minutes, that baby is still considered technically premature.
How about underweight?
Underweight.
Underweight babies, okay, that's the thing. Even if the age, that's of course the age of gestation I'm talking. The complicated newborns, of course, what is the answer for your question? It seems that you know the answer for your question. You're just testing me if I know it.
Yeah, I mean, if it's a less
I
than
feel you,
6
I feel you. You're just challenging me if I know, of course, my stuff.
If it's a less than 6 pound of baby,
Convert it in grams. We want pounds. The pounds weight is only, of course, for the mother in the family. Technically, when we weigh the baby, wherever you are part of the world, even in birth certificate, it should be, of course, metric system. It should be, of course, when we speak of metric system, it should be in grams. Why? For the purpose of legal documentation, it should be stated right always there. We have two. One in metric system, another one in pounds. But the pounds will be only, of course, for the benefit, of course, of the parents and other people. Why? What's the reason why we put, of course, and weigh the patient and we record it legally, of course, in grams?
For medication.
Huh?
Medication.
The first thing, of course, for the one is that for medication purposes. In standard, that is the SIU, of course, of birth weight. Okay, now my question will be, I don't understand. Okay, now you want to give yourself a hard time? 5.5, you said below 6 pounds. I don't think so, but 5.5 pounds is normal. 5.5 pounds to 9.5 pounds are still within the normal parameters. Now my question with you is that, now I'm telling, of course, age, and then the question will be, how about, of course, for babies who are very, 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 of course, low birth weight? Okay, we call them very low birth weight infant. Okay, or another term for that one is small for gestational age. Okay, but now the question will be, what is the weight of the baby that, regardless of age of gestation, is still considered premature?
less than 200 or 300 grams.
Just 200 to 300 grams, of course, it's lesser than a hamburger. Come on. You're eating from McDonald's, it's about 350 grams hamburger. It's too small.
600?
The baby, of course, about 350 grams, of course, cannot survive. 350 grams, the baby, of course, is still pregnant only, of course, for around, the AOG would be around, of course, only 14 weeks.
600?
60.
No, 1,000, I think. Yes.
Baby who are born, yes?
I think 1 kilogram.
1 kilogram is how many grams? Tell me.
1,000 grams.
Oh, 1,000 grams, so below 1,000 grams.
2 times 2 pounds.
2.2 grams, okay. So again, that's the question, of course, I would like to ask. Later on, for the complicated newborns, we're going to answer to one. But technically, babies who are born, of course, below 2.2, no, 2.2 kilograms, okay, will be considered, of course, as low birth weight. Technically, of course, the baby should be above 2,000, because a baby who is below, of course, 2,250 grams is low birth weight. And usually, by any chance, regardless of their age, will be considered. Or the only thing for that is that they are not premature. They are low birth weights. The only difference is that, technically, to define it, they are not, of course, premature. But the greatest difference, as you have seen, of course, or read in the books, will be the care we give to a low birth weight to infants is the same care we give to premature babies. Clear? That's that to be technically, of course, different for that one. If you want to capture me ahead, because ahead of the, of course, of my game. But again, that's the technicality of it. Okay. But the age, of course, that will be decided. But the care we give will be the thing. But again, when we document the age of gestation, regardless if it is, of course, 41 weeks, if it is low birth with infants, the care we give, because their possible survival will be very low. That's why weight is a very important thing to assess with the baby. Clear? We don't want them very low. We don't want them very big. Or else, the mother will have a hard time delivering it vaginally. Okay? Especially if the father is not that big. Okay? Following information obtained when the labor began. Okay? We have to document that one. How close the contractions are. Those are the questions we need to answer. How long each contraction lasts. So again, how close are the contractions? What's the term? What is the one documenting how close the contractions are?
1 minute.
No, what is the term we use?
Duration.
Nope.
50 seconds.
Nope. Interval. How close the contractions are. Interval should be?
Less than
It should be greater than 2 minutes. Okay? The maximum, the closest will be 2-minute interval. That's the maximum. But commonly, before the reach, of course, that period, baby is out. Okay? But that's the maximum. So that we have, of course, rest periods. How long is contraction last? Duration. Okay? Ano?
No.
Duration will be, again, interval, not less than 2 minutes. Okay, duration, not longer than 90 seconds. 60 to 90 seconds. But 90 seconds will be the greatest number. We don't want the duration, or else there's no time, of course, to relax. The baby, of course, is not receiving oxygen. Remember, each time the uterus contracts, no oxygen or limited oxygen is being given to the baby. Therefore, it has to relax for the placenta to suck more oxygen from the mother's blood. Whether the client has noticed any bleeding, show, or any, of course, abnormalities, of course, during, of course, the labor. Eh? Whether the bag of water has ruptured, what do we use? If we don't know, two things. If it's still intact, it is, of course, we have to, of course, to rupture it, and it ruptures through two ways. Natural, spontaneous, we call that one, of course, SROM, spontaneous rupture of membrane, or another one, 75%, we have to rupture it ourselves. If you are attending the birth, we call that one your artificial rupture of membranes, or we use of amnio hook, okay? But again, what if you don't know if the bag ruptured or not? So you have to test, of course, if we have presence of amniotic fluid. We can test the one with the use of your nitrogen test. And we nitrogen test, we are using a strip colored yellow. Okay? If it remains yellow, if it remains yellow, the environmental fluid test is acidic. Therefore, it is vaginal secretion. If it turns blue, it means it's exposed to alkalic environment. Therefore, we have a leakage, or our bag of water has ruptured. Remember, even if it's ruptured, there is no dry labor, because as long as the baby inside, the amniotic fluid or the amniotic sac is still producing amniotic fluid until the baby is out and the placenta is expelled. Okay? Therefore, dry labor is a myth. Clear? Okay. So anesthesiologist certified nurse anesthetist, of course, will want to know where the client last ate. Because again, that's why we don't want as much possible for the woman to eat during the active phase of labor. The risk for that one will be, both high risk will be, if the woman ate, the woman could be hypotensive, but the worst thing that we're going to do, of course, is that the woman will going to puke out. Because of the contraction of the uterus, it will going to make the woman vomit, and the risk of always of vomiting will be not fluid or electrolytes. That's later. The most highest risk of vomiting is no other than aspiration to the lungs. In the woman is, of course, supine, so the risk of aspiration is very high. We don't want the woman to develop the major complications, of course, of lying down, pneumonia. Clear? In care, airway first. Make sure, of course, that the airway in the woman is breathing, okay? So that's the thing. Therefore, I would like, of course, for you to present to you that usually nursing, of course, techniques in the way to analyze question is more of a mindset. How do you think as a nurse? And that's what I want for you to develop. Okay? So you're always critical. What if? Usually, sometimes you do what if, but I know, I'm not convinced, of course, that this is the problem. And once you have the problem and you identify right away the problem, now you will react to that. Based, of course, on your training and based on your knowledge, of course, on your anatomy and physiology. Okay? So report bright red bleeding at once. So after once, because again, why? It means that we are bleeding somewhere. Either the bleeding will be the primary source of bleeding, usually is the inside the uterus. What if you have laceration, of course, of the cervix? What if the vaginal canal has laceration too? And it is not contained, it is not stopping the bleeding. Therefore, it needs, of course, to be, of course, evaluated further. A client who is bleeding should never be examined vaginally until ultrasound rules out placenta previa. This is if the woman, again, has not yet fully delivered. But in the event, of course, I thought already are stage 4, this is stage 1, okay? This is the one I think, of course, I said, of course, that during, of course, if the woman has bright red bleeding at once, it is not a bloody show, especially if it is profuse, okay? It is not a show, because show usually, of course, is a mucoid with a tinge, of course, it's a mucus, just like a tinge, of course, of pink. But if it's a severe, profuse, bright red bleeding, the next thing, of course, that we know is placenta previa. Never examine vaginally because you will be dislodging the placenta. And again, do not break the rule. Baby first before the placenta. If that will be the case, placenta previa, the baby will be dead first before it will be delivered if you deliver the placenta first. Okay? So now, ultrasound. If you do check with ultrasound, full placenta previa, again, we call that one usually, of course, as your stat CS. And usually, if somebody there is figured for liposuction, those liposuction will be removed out or delayed, or any other element that is not emergent will be, of course, thrown out of the theater. We call the theater OR. And then put, of course, the woman right away to save both the mother and baby. In terms of emergency, OB emergency is in the top of the list, always, of the ORUs. Okay, because why? We have two lives at stake. Okay? That's why I remember before, I love it, of course, when you are doing, when I'm doing, of course, OB, because why? As if the OB, of course, is a god of OR. No, I need the theater, the OB said. I have, of course, a fetal distress. So sometimes other surgeons will be, oh, well, can you do, the boss says so, the God says so. Where they are gods of OR, because they need, of course, to utilize right away. Okay? That's how greatly we give, of course, emergency, of course, because, of course, of the two lives. Yeah? So routine procedures, as I have said, of course, during the time of the labor, head to assessment of the mother, urine dipsticks testing for sugar and albumin, urinalysis, hemoglobin, hematocrit during, of course, of sex, if we need to have the baseline. Okay? Mother's blood type, we have to know it, isn't it? Fetal heart tones, it's very important. Again, when we speak of fetal heart tones, if it's in the hospital, we have two ways of monitoring it. Okay, the first one is that, how do you monitor these things? How do you monitor duration, interval, of course, of the contractions? Do you time it? Do you watch it there? What kind of machine is that? Tell me.
I don't know the fault.
Do you know what is the technical term, of course, for the contractions? What is the technical term for contractions? What is our technical term? So, like, for example, what's the technical term, of course, for uterus? Hystero. Isn't it? What is of course the technical term, of course, for your mouth? Orum. That's why per orum. Okay? Orum. Isn't it? What's the technical terms, of course, of your, like, for example, the like foot? Pedal. Okay, see? Now my question will be, of course, what is, of course, the technical term for contractions? Because we have. And I don't want you to forget about it. This is, of course, terminology. I think, who taught you medical terminology? Because they didn't teach you that. Because it's already more specific, of course, on OB. Okay? The term is TOCO. If you see this one, it reflects, of course, to contractions. Okay? So that's why, if we want to monitor the contractions, what we're going to do, of course, use, of course, a TOCO machine. The TOCO machine will be very good. Dynamap, the port of blood pressure, isn't it? Dynamometer. Okay? So that's the thing, of course, that you put the strap on the belly to monitor, of course. But the only thing is that it will gonna graph, it will gonna give you the duration, the interval, but never the intensity. There's only one way, of course, for us to check for measure for intensity. And that is, how do we measure intensity of contraction? Externally.
No.
You have to put, of course, your gloved hands on the fundus of the uterus and feel, based, of course, on those things. Okay? If you can still dimple or push in, of course, the uterus. That's the only way. Does TOCO dynamometer give you the data for intensity? The answer is no. It will only give you duration and interval. Clear? Okay? So we strap the woman with the TOCO dynamometer, okay, in order to monitor the frequency and duration of the contractions, to know the progression of, oh, we're already in active phase of labor. Besides, of course, that, we have to do an SVE, sterile vaginal sign, vaginal examination. This is why the contractions will go hand in hand in duration to your sterile vaginal examination, the amount of dilation and the amount of effacement. Okay? So first one, strap the mother, of course, with TOCO dynamometer. And later on, how about, of course, I give you a word, okay? I want you to give me the definition. First one, TOCO is? Very good. Very good, children. Lytic means, not lytic, of course, lytics, okay? From the word? Mayo, muscles of Mayo. Lytic from the word? No. Gland is not, it depends. We have a lot more in terms of glands. From the word, lysis. I know. Dialysis, of course. It's good at one, but it's a lysis word. Lysis means dissolve or crumble. That's why, of course, when we speak of lysis, you dissolve it, you squeeze it, you remove it. Okay? You meaning to say, you lessen it, you lyse, you dissolve it. That's why. Dissolve the therefore, these are the medications that dissolve the contractions. We give this one for women who have contractions through labor before reaching 37 weeks. Therefore, tocolytic drugs are drugs given to a woman to dissolve the contractions, okay, in order to progress the age of gestation. Because our goal will be no delivery as much as possible below the age, of course, of 37 weeks. We call it one premature labor, and premature labor, of course, will lead, of course, into prematurity of birth. Okay? And by any chance, we don't want any baby born premature because of the risk. There's a lot of risk. Poor babies. Very hard, of course, for the parents as well as, of course, for the baby himself. Okay? So you see that one? If you get, of course, the meaning and you can chop these words, you can crack, of course, the words. That's only if you know, of course, you are good in your medical terminology. Okay? So I'm only showing you once because, of course, of this one. So sterile vaginal examination, we help you know that. Make sure that, of course, the woman will not be allergic, of course, to betadine. Betadine, because betadine is the one, of course, that we don't shave the women anymore. Before we shave them, we bald them. So sometimes before, of course, ending out, you cry. Of course, I'm going to do, of course, a smiley face. No, we don't do that one anymore. Right now, we do swabbing. You get, of course, a soap, of course. Usually we do, of course, a cotton balls, or usually, of course, an applicator, of course, for betadine. We use, of course, swab it zigzag. Do we remove the pubic hair? If the woman has pubic hair, we don't touch it. Because the risk of infection to a woman is higher if you shave them, because you might expose, of course, all those scraped edges of the skin rather than to put betadine. We know that hair is a fomite, meaning to say it could harbor, of course, microorganism, but it is safer for the woman to of course, to swab it with betadine. We don't shave it anymore, okay? Usually it's a practice with betadine. That's why we want to check the woman if the woman is allergic to betadine, okay? Betadine is, of course, povidone iodine, okay? Another one, lidocaine. Lidocaine, of course, we have a lot, of course, of medications. Lidocaine is the most common anesthetic, local anesthetic we use. We usually use this one, of course, when we inject, of course. Usually, sometimes we could inject, of course. When we cut, we don't inject. But when we repair, because the woman will going to feel already, of course, the suturing, we give, of course, lidocaine. And lidocaine is the most common local anesthesia we use. Clear? Local. But later on, we have, of course, Novocaine that we can use, of course, epidural. Because epidural is the most common form, of course, usually of anesthetics we use in order to numb, of course, the lower part, okay? To lessen the pain, of course, when the baby is coming out by the mother, okay? Allergic reaction can range for this one. Another one is latex. So latex, because we will be using a lot of gloves. If the woman is allergic to latex, then we have to use, of course, nitrile form gloves. Sterile nitrile or nitrile form type of gloves in order, of course, to prevent exposure to latex. Okay? So danger signs of labor, what are those? What's that? Number one is bleeding, isn't it? That's why I don't want my pregnant woman to bleed until such time that in the least time, of course, for her to deliver. And again, I don't want her to bleed. Usually I want her to bleed only, of course, when? One, with the placenta is separated. But even, of course, during, of course, the entire delivery, there might be tinge of pinkish, of course, things, but I don't want the baby to come out, of course, smeared with blood. I could see, of course, the babies smeared, of course, with the mucose, of course, isn't it? And another one is that with a lot, of course, of with a lot of membranes, but not necessarily, of course, with blood. Okay. So those are that's blood. What else? Contractions that are greater than. What are the greater than, and with interval, of course, greater than, less than 2 minutes. Again, less than 2 minutes. That's high risk. And duration of contractions greater than 90 seconds. Okay, those are high risk. What else? What are the risks there? According, of course, to the table.
Irregular fetal heartbeat.
Again, fetal heartbeat. Fetal heart tone, that's R.
120 to 160 maintain.
Maintain it. But again, if we're going to go down,
Less than 100.
we want it to go down, not less than 100. Okay? How about if the heart rate increase? Is it an abnormal one? Depending, of course, on the increase. But if it's the increase is only 15 beats per minute, especially if the baby is moving, we call that one acceleration, not a deceleration. And again, acceleration or increase in the fetal heart tone, when you stimulate the baby, is a healthy sign that the baby is alive. That's why we call it one, the baby is alive. And, nope, there's another one term. Alive and?
Kicking.
That's the term, of course, that we need, of course, because we know that the baby is reacting to stimuli. That's an OB term. Alive and kicking. It's for the fetus. Uterine contractions. SVE performed by midwife, obstetrician, or registered nurse. Could a registered nurse do, of course, SVE? Yes, we do here, if you are an RN, especially if you're trained in OB. Okay? So we could do that. Cervical dilation and effacement. So we know that one, isn't it? Starting from show, hopefully, of course, it will gonna progress, of course, to 100% and 10 cm. 100% effacement, 10 cm dilation. Determine the presenting part. So again, what are the possible presenting part? What is that? No, that's placenta. We're talking about, of course, on the first one.
The presenting part will be the head, the cervical part, the part that you see when you look at it.
Okay, so what is that?
Crowning.
Give me one. Crowning is the stage when we see, of course, the presenting part of the baby outside, which is usually the head. But again, we speak, of course, of determine the presenting part. Tell me, what are the possible presentation?
Limb.
Tell me technically. Occiput presentation. Left occiput anterior. Right occiput anterior. But I don't want any occiput posterior. Okay, because this is very hard to deliver. Okay, this is one of the most common abnormality. Okay, how I wish I could turn right away, of course, the fetal head. Okay, what else? What are the presenting part possible? In breech, that is of course your position. I'm talking about presenting part. What do you see? Imagine fetal head.
Yeah.
Yes, it could be the occiput first. It could be, of course, the brow. Still fetal head. It could be the mentum or the chin. Okay, what else?
Leg.
The leg?
The forehead.
It is a presenting part, or the butt. Would be a presenting part. We call that one, of course, as your breech, of course, position, and sacral presentation. Okay. What was the last possible one that is not compatible with vaginal delivery? What presentation? Acromion presentation or shoulder blade presentation, which in terms of lie, we call that one transverse lie, which is not possible, of course, for normal birthing through vagina. Clear? Okay? Station?
0.
-3 first. Meaning to say 0 until it descended to 0. In 0, we call that one a shore. Full engagement. Okay? And progress to +1, +2, +3. Full crowning. Again, we will be, of course, acquired, of course, in +4. Okay? So +4, by any chance, the doctor should be there. Because +4 is?
It's on the floor.
Very good. +4. I want you to repeat that one because you don't want, of course, to wait for +4 to pass without the doctor attending, or else the baby will gonna. And don't worry, if the baby is brought out, okay, drop the baby, a newborn, 1 meter, of course, from the floor, even if it's concrete, there will be no harm for the baby. That's how flexible the baby is. That's the gift of the baby.
Wait, so if it hits the floor, nothing's gonna happen?
Nothing gonna happen. Nothing grave gonna happen to the baby. That's how is baby protected. So again, even the bones, of course, is very pliable.
They're like eggs.
Correct. Okay, they're like eggs. If they drop, of course, properly, but usually 1 meter. That's what they said. That's what the book says. If you drop, of course, with at least even if it's 3 feet from the ground, okay, and you drop the baby, there will be no injury. Most commonly, no injury, of course, will occur to the baby. That's how how protected the baby is. Okay, but okay, that's one. The station and the pelvic inlet. Another one is that before, of course, the thing is that the birth plan will be. I will have to go back again during the pregnancy. Now, so again, the woman is pregnant. The OB said, what kind of delivery you want? Because the OB now is asking for the birth plan, isn't it? So the woman said, doctor, I want, of course, to experience what my mother experienced because I was delivered vaginally. I want also, of course, to deliver my baby vaginally. Before the OB will gonna agree with that thing, okay? Besides, of course, checking the fetal size, the next thing is that we have to do an important study or test. We call it one as your pelvimetry. What is pelvimetry? If the woman, of course, will be this is, of course, the bone. So again, okay. So this is, of course, the pelvic inlet. I'm talking about, of course, the pelvis. Okay. So the most important in pelvimetry, we have to measure this one from this point, anterior portion, of course, of the pelvis. Okay. In the mons pubis area, we have to measure the posterior, of course, portion, of course, of this one, of this area here. Okay. Sometimes this will gonna be a problem. From this position, of course, we have to measure, we call that one as your AP. Antero-posterior diameter. Okay? If it is wide enough, the doctor will say, okay, you can deliver baby. But some women are not gifted with this kind, of course, of pelvic bone. We call this type as your gynecoid. Gynecoid is the best form, of course, of pelvis for a woman. This is a bone structure. There is nothing we can do about it. What if the woman, of course, is born with the pelvis just like this one? We call this one as your platypuloid. When you come back, of course, for your BSN, or you will gonna be doing this one, but I would like, of course, to present to you that this pelvimetry is very important to make sure that, again, we have enough angle, we have enough diameter, this one anterior posterior diameter, to allow the fetal head to be delivered. Because if it's platypuloid or very narrow angle, then a narrow anterior posterior diameter, the doctor said, by any chance, you cannot deliver baby vaginally. Because the baby cannot pass through the pelvic inlet. Okay? So this is an important thing. Before the doctor will gonna agree with you with the OB. That's why we want the pregnancy and delivery to be guided with the OB in order, of course, to measure that one. Okay? Because we don't want, because whether you like it or not, if you have, of course, this type, baby cannot come out. And the baby and the mommy will just die. So the only way to do this one is, of course, is that, not only, of course, to crack this down, but again, we have, of course, to deliver a C-section. Yes?
No, because I was going to ask the question, like in Africa, the people in the remote area, they don't have a prenatal care. Things like that, they don't have any testing done. And they don't go to hospital. So when they begin to have the baby, so that means, and they can deliver vaginally. So that in that case, they probably might die then, because they never know.
Not probably, they will die.
Yes.
Both the mother and the baby. Unless otherwise, again, some of course of your cultural midwives there could crack this down to allow the baby. But usually that is not the case. Even if this will be the time, they cannot even handle. The one that they could handle is that a gynecoid pelvis with but the baby has a very big fetal head. We call that one CPD, cephalopelvic disproportion. That's a complication, of course, later on we're going to do. CPD, cephalopelvic disproportion. The cephalic part of the baby and the pelvis of the mother is disproportionate. Meaning the fetal head is very, very big. Even if it will going to overlap the skull, it will not pass through. Just imagine if this is the pelvis of the mother, the fetal head is this one. How would it pass through? Okay? This is very common when, of course, the glucose control of the woman is not controlled. These babies are giants. They are usually above 9.5 pound babies. Or up to, believe it or not, I saw babies, of course, that are 15 pounders. Okay? And there's no way you can deliver it vaginally. The C-section. These are the babies of the mother. We call this one as your giants. The technical term for that one are macrosomic babies. We call this case, of course, of macrosomia. Macrosomic babies, of course, cannot be delivered vaginally. C-section. And these babies are usually the offspring of the mother who are either diabetics or having gestational DM. That is why the first control, of course, we want, of course, to evenly distribute and properly control, of course, the mother's blood sugar, especially if they're diabetic before, or else the baby will get a suck in all the glucose, of course, from the mother's blood. Okay? That's why we don't want any bread, pop. These are, of course, the quick calories, of course, that the mother could take, which is going to cause, of course, a rapid, of course, change, of course, in the blood glucose level. We want it to be high, to be not extremely high. We want it, of course, to be enough in order to sustain the nourishment of the baby, but not high enough that the baby will gonna suck in, because the baby's pancreas is healthy enough to produce insulin. Therefore, the more glucose you give to the baby, expose it from the mother's blood, the baby's pancreas will gonna produce more insulin. So the end product will be the baby is sucking all the glucose in the mother's blood. So the result will be giant babies. Okay?
Mr. Lilio,
Yes.
what's the name of the third one that you did?
Which one?
The one that can't deliver to
CPD.
CPD?
Cephalopelvic disproportion. These are, when I speak, of course, cephalopelvic disproportion, this is, of course, a condition where in the fetal head, the head of the baby cannot pass through. They are disproportionate. So basically, when I speak of cephalopelvic disproportion, fetal head is extremely bigger than the outlet of the mother, pelvis of the mother.
But it doesn't mean that the pelvis, there's something wrong with the pelvis.
It could be not necessarily, of course, the pelvis, something wrong with it. Usually, of course, it is a very big babies.
Okay.
Okay? Which is the most common. Platypuloid. Don't forget about the flat, okay? I don't want to give you the technical because I don't want you to overburden with this one. So we're going to talk about that one when you come back, of course, for your BSN or RN degree, okay? Flat. We call that one flat. Okay? The other one is, this is of course a heart shape. There are some people of course who are narrow and wide, especially this one. Usually, this one of course is just like a heart shape, okay? There are some people of course who are pelvis of course that are round, okay? These are round and smaller. We call this one the pelvis of the man. That's why we call this one technically as your, if you don't have any iPhone, you go to one as your Android. Android means manly. Okay? The keyword for Android is of course it's of the man. Gynecoid, a woman's pelvis. Android is a man's pelvis. Round, narrower. So again, that's why a man's body can never deliver a baby. It's not equipped, of course, with the pelvic, which is important later on, of course, as we progress along. Okay? Okay, that's it. So gathering, SVE, we know that one. So comfort, emotional comfort. Again, if the woman is in labor, how do we lessen, of course, the effect, of course, of contraction pains or contractions? So usually, why is that? Usually, of course, in true labor, you see, of course, the woman walking, and then all of a sudden, in the middle, of course, of downward, begin contraction, and their position, as you can see, what would they do? They would. You see this one. They support their back because again, the true labor, the pain will be starting on the back and around, of course, the corner. Okay, that's why one technique, of course, we do is that if the woman is in pain, we apply pressure on the sacrum. We put counter pressure on the sacrum. That's the only way, of course, that it will lessen, of course, the contraction pains. Okay, that's one thing that you could do, of course, as a nurse. Does it require doctor's order? No.
I don't know.
Do you think? Did you deliver your baby vaginally? So, do you think Tylenol could handle that pain?
No.
Then why did you answer, of course, for Tylenol?
No, you say they do pressure, but they didn't give it that. They said you just give Tylenol. This was all trying to say.
Class, who gave you Tylenol, of course, for your labor contractions? They gave you Tylenol, true? What did you deliver?
Huh? No.
Which hospital is that?
Because, no, here.
But I would like to
She
know.
gave Tylenol for pain. And then,
And what kind of pain is that?
back labor.
No.
They say I don't have 39 weeks, so I cannot have any IV and epidural. It's
So that's what your doctor
something
said.
law, yeah. So I cannot have anything, just Tylenol.
So, if you ask. Okay, this is funny, but again, the goal for that one is that never give any form of narcotic management. Because again, it will be detrimental to the baby. Tylenol could be, but what the Tylenol? If you are in true labor, that's
I
why.
was in true labor, but
Are
they
you in
said
true
we did-
labor?
Back labor, I had it and not now.
Oh. But are you in true labor when they give, of course? Did they find a true labor, of course, for you? Are you dilating? How much dilation you got? When they give you Tylenol?
I was 3, but I had a back labor. And then I went home and then I start again and my doctor
Because
said,
I'm going to show who, that's
Go
why I
back,
said,
yeah.
go back. Come hurry, we are already around 6 to 8,
Oh, my-
usually the doctor. What did your doctor said?
no,
Come
my
back.
doctor says
Go home and then come
No,
back
my
when?
yeah. Then she told me to go. I went to visit her clinic
Okay.
next day. And then she told me get admitted at 6 o'clock, like 6 o'clock evening.
Okay.
But I didn't go.
Why you wait for until?
Yeah, because I know she gonna send me back. I was not dilated.
Oh. Okay.
But
So
they
this-
said- they
I-
keep
I
you
waited
at
until
4
11
centimeters
o'clock.
too.
Huh?
They keep you at 4 centimeters too.
It could.
Yeah.
If it is you are entering an active phase, but the last time we don't admit you.
In 4
But again, remember is that they could admit you at 4. But again, remember it is me. I want my women, of course, to be at 8, 6 to 8. 6 I will be or else. Because remember, during the time, I need to deliver the babies within 2 to 3 hours. Because you know what's the main concern?
Mine went fast.
No, but again, that's why I wanted that one, because during that time, I'm a very, of course, great smoker. I have to smoke between 2 hours of the work. So I want my women to deliver within 2 to 3 hours periods because I would like to get out and puff some smoke. I was gonna die without smoking. That's why that's the personal thing. Okay, that was a thing of the past. I've been smoke free, of course, for 3 years. But again, for those smokers here, you can invite me, of course, for a stick of a smoke or 2. Okay, when you pass your NCLEX. Okay, I'm gonna dare you. Come back here, ask me to smoke. Show me, of course, your license or certificate, of course, of license. I'm gonna smoke with you. Even I quit already. Even I know the dangers of smoking. Okay, that's what my challenge, of course. And again, don't ask me to drink with you. until such time that you have passed your NCLEX. By the time we can go drunk. Do you get what I mean? That's why I want because a lot of course of students sometimes usually invite me for no, I don't go. Because we're not at the same level. We are only at the same level if you have your license. You are a nurse and I am a nurse. Okay? In that perspective, I want, of course, for you to start to strive at one. If you want me to, I'm open. Come back here for those smokers, and then we're gonna smoke. I did it several times already.
When can you give the epidural?
Depending. Okay? But usually epidural could be given. I want the epidural to be given again. Okay? Towards, of course, usually, of course, I want it to be given the earliest I could will be 8 c.m. You get what I mean? For me. But again, it will be, of course, the woman's choice. Remember that. But to be safe, of course, because 8, it will be, of course, looking at a 2 to 4 hour gap, maximum, in order the baby will be fully delivered.
When is it too late to give the epidural?
Okay, when the baby is almost coming out, in the mother's script, pain, then if you have crowning already. If you have crowning, and you deliver, of course, the epidural, usually, of course, it could be absorbed still by the baby. Remember, the baby still is sucking mother's blood through the placenta. So sometimes it could be at 4 cm if the woman is, doctor, I cannot stand it anymore. I cannot.
No, they don't give.
They don't get it.
No, they don't give until they're
Well, a lot of women could act out. They could be, I'm agitated. I'll be palpitating. You should the doctors. But again, they have to manage you with the condition.
They got a law. Nobody can be given.
Okay, but again, whatever was the criteria, but again, I see of course the doctor has to give in. Okay? Because of the condition.
But at centimeters at the hospital I delivered at, they won't even give you the epidural
Yeah,
because
they
they
don't
say
give
you're
it.
too close to deliver.
Okay? So when do you want of course to deliver to you? 6?
Yes.
I don't want it 6, of course, because again, especially if this is my primary. But usually doctors could give you at 6, okay? And as a matter of fact, there are some doctors who could give you at 4. Although 4 is very, very early. Because again, we don't want any fetal, I don't want, of course, any, of course, because again, sometimes, if you give, of course, at 4, it will take another 8 to 12 hours to progress, of course, to 6. It's not progressing properly. So we have to start Buscopan again to ripen the cervix. Another medication in order to progress the labor. So sometimes one medication prevents, of course, the progress of labor. We have to give another medication on top of that because we want, of course, to push out, of course, the cervix. We have to ripen the cervix. So sometimes we have, of course, a medication to do that one. But usually, of course, with me, of course, the latest will be 8, but again, 6 will be fine. Will be fine with me. But again, for me, if I will be choosing it, that 8, because again, why? There's a progression of course with 8. 8 for me is the best timing, of course, to give the epidural. Okay? Because sometimes usually the hospital will not give you the 8 because it's too late. Because again, the progression between 8 to 10 and full dilation delivery will be less than 2 hours. So we don't have any withdrawal, of course, for the baby, of course, to undergo for that one. But again, 8 for me, of course, will be the maximum. Okay, that you can latest, of course, you could give. 6 will be, of course, usually was recommended.
8
Yes.
hours? Did you say 8 hours?
No, 8 cm.
Centimeters.
We're talking about dilation. We're talking about dilation. And again, with the 2 to 4 hours margin, for me to smoke after that one, or for the withdrawal of the narcotics, I want it to be that way because again, why? I don't want it to be late, I don't want it to be later. So again, when I speak of hours, it means of course the timing, the duration, or the gap between of course my 6 cm to 8 cm, or my 8 cm to 10 cm before the baby is out. Okay? Because again, remember, we can only deliver the baby if we have full dilation, which is 10 cm. What's that?
Shall be in so much pain.
So that's why, again, they give a value, of course, tayo, no?
Yeah.
That's why instead of telling, because sometimes it's not working, I usually, okay. Usually before, when I was still younger nurse, of course, doing this, I have to follow by my pregnant woman in the labor room. Okay, we do this one, they do that one. I have to push it, I have to kneel down even, of course, okay. Breathe, pant, and I have to push, of course, the sacrum in order to put counter pressure on the sacrum to lessen, of course, the contraction pains.
They just send home. This one send election people.
No, but that is, of course, because you are below 4 cm. But if you are already admitted at 4 or 5 cm, so usually the frequency will be, then counter pressure, sacral counter pressure will be one of the most effective way, of course, to do it. So again, analgesic, sedatives, tranquilizer. Again, why I use this one? Because sometimes a woman who is at 4, they would give her, the woman will gonna scream, and they will be hysterical. So what should you do? You have to contain the woman. So we have to sedate them. One way was to sedate them, give them a little pain medication. They will relax. Okay? That's why. I don't know. But usually standard-wise, no. Usually the nurses will gonna, no, we cannot give you anything. Sorry. Okay? Because it's you're only 4 cm. So that's it. But again, there's a lot of women, especially if you are, no. If you are having a patient who is having delivery who is a nurse. Okay? The worst patient in the world is a nurse. Doctors could be better, believe it or not. But nurses who are doing bedside, they are the worst patient. Holy crap.
Patient?
Yes. Nurses are the worst patient in the world.
Because they know everything.
I don't know why. So that's why, again, if I have students before and they will be my nurses, I'm going to, remember, if I'll be hospitalized in your hospital later on, okay, especially younger population here, I'm going to give you hell. Okay, tranquilizer, antiemetics, okay? So sometimes antiemetics could be given, especially if there's no shaded. Because again, why? We could give antiemetics because we don't want any vomiting, we don't want any aspiration, especially in the midst of labor. Okay? Epidural. It's one thing. AKA your lumbar epidural, saddle block, pudendal block, cervical block. Cervical block is on the cervix alone. Pudendal, we block only, of course, the vagina. Pudendum, the vagina, only the area there. In saddle block, of course, will be around it, but the best one is the most recommended one is epidural. It will numb, of course, around, of course, all the organs there. Yeah. So after consulting with the provider, once, of course, decision, that's one, of course, the thing. Now, after anesthetics, of course, if the one is given, you have to check, of course, the effect, of course, of over medication of over anesthetics. Inability to move legs, that's the most one, that's over anesthesia. Numbness in the leg, ringing of the ears, metallic taste, hypotension, and seizures. Remember, anesthetics drops down blood pressure of the mother. Dropping of the blood pressure of the mother while the baby is still inside will decrease the oxygen flow to the baby. Remember, it could cause fetal distress. That is another reason why we don't want, of course, to give anesthetics very early. Okay? If you're gonna give it to the one of the risks, the common risk is if you give it around 4 or below 4 anesthetics. We see, of course, some cases that the baby, because of hypotension of the mother, we saw babies, of course, who had meconium stain. Because why? They don't receive enough oxygen, so they have to poop inside. So it end up, of course, with meconium stain. We end up, of course, we call that one as respiratory distress, of course, with the baby when the baby comes out. Okay? So that's one of the risks, of course, besides, of course, respiratory depression or delayed progress, of course, of labor. So FHR, first thing, when you speak of FHR, tocodynamometer, dynamometer. No, it should be dynamometer. So that's one only for contractions, 2 things, duration and interval. It will gonna give you a graph printout. But sometimes our graph printout, one graph on the top, another graph on the bottom. The bottom will be your fetal heart monitor, or FHM. Okay? FHM is not for him magazine, okay? FHM is fetal heart monitor. Okay. So normal heart rate, you know that. We have to close this one. 2 things. When we are still open cervix, again, the criteria here is that when the woman is in labor, before, of course, the rupture of membranes, we put, of course, another, of course, probe outside. Okay? Just like, of course, the stethoscope. We call it one of the probe, of course, of the ultrasound, but we put it, of course, in the mother's belly. We locate, we're in, of course, the fetal heart tone will be the greatest, of course, on the back. So we locate that one, we strap it on the mother. Therefore, there are 2 forms of fetal heart monitor. First one is the one that we strap outside. We call it one ashore. External fetal monitor. Now, take a look for this one. We check it one, the labor progresses. And sometimes we have artifacts if we have external fetal monitor. Because sometimes the movement, the placement, the movement of the mother, oh, what is that one? It's not giving me enough, of course, strips or enough reading. So because, of course, of the artifacts that it could be. Okay? Now here comes, of course, the bag of water. Ruptured, spontaneous, and usually right away with the fetal head, when we can palpate, we can insert our finger and touch the fetal head. Okay? Even if, of course, shall we say, of course, it is in station 1, +1. Okay? The next thing the nurse will gonna do, of course, will be insert, of course, a clip, but the most common one is a spiral. It's like a screw. What we do is that is screw it in the hair of the fetal head. Okay? We call that one as your internal fetal monitor. That is the best way to monitor the baby because, as a matter of fact, when we put, of course, a clip on the head, of course, of the baby, usually on the hair, or spiral on the fetal head, the thing we could do is that we could even check the ECG, the beats of the heart of the baby. Okay? That is one of the most accurate monitoring of the baby. And once we put, of course, the internal fetal monitor strip, or usually by either a clip or a spiral, then we are good to go. And again, there are no artifacts, of course, that we can see. And it's more accurate. That's the best way, of course, of monitoring the baby. And we could monitor, of course, it with your, attach the probe, of course, to your fetal heart monitor, the fetal heart monitor, and we will know, of course, the changes. And usually, of course, later on, we're going to compare, of course, the contractions of the tocodynamometer in the fetal heart rate on the bottom, if we have some changes. Okay? So 2 forms of monitor. First one is your tocodynamometer for the contractions and interval. Second monitor will be fetal heart monitor. First one will be external, strap, of course, on the mother's abdomen. The second one, that's internal, can only be applied if the membranes or the bag of water has ruptured. If the bag of water is not ruptured, you cannot insert an internal fetal heart monitor, either with a strip or a spiral. Okay. Electronic fetal monitor, or EFM, fetal distress, induction, chronic heart problems, pregnancy complications. It is, of course, our way of monitoring the baby if the baby is better taking, of course, the progress of labor. Okay, now, we have some terms, acceleration, decelerations. Okay? So this is, of course, our tocodynamometer. Tocodynamometer. Okay. Now, we have some changes. We call those things, of course, as your acceleration and deceleration. Okay? Acceleration first is defined as increase in fetal heart tone. Okay? Normally, of course, acceleration is a healthy, of course, sign, of course, of response of the baby, as I have said, especially if the baby is moving. Okay? Commonly, of course, is that the increase, shall we say, 100 to 120 to 160, the increase should be commonly will be within 15 to maximum of 60. Clear? So again, if the heart rate is 120 plus 60, that will be 180 still. Okay? So now, if it is, of course, 160 plus 60, it will be 220. Okay? If it reaches that point, of course, it will be abnormal. Therefore, it should be below 60 beats acceleration. It means to say, of course, that it is still within the parameters. But a heart rate increase, or a fetal heart rate increase of 60 and greater, is a big problem. Why is the fetal heart rate has a fetal tachycardia? It needs to be investigated. Okay? And it is also labeled as fetal distress. Therefore, by definition of fetal distress in terms of fetal heart monitor will be, definition will be a fetal heart rate that accelerated of 60 beats or greater. That's one definition. Another one later on is what fetal distress, a heart rate of deceleration, meaning to say it went down below 100 beats per minute. Clear? Therefore, what's the normal heart rate? Below 100 and greater than, of course, 60 increase on the baseline. Clear? Do you get my definition, of course, of what is fetal heart distress, or what is fetal distress? Those are the thing. Or the baby is not moving anymore, then probably this is fetal distress. But in terms of fetal heart tone or fetal heart rate, those are the technical description, of course, if the baby is in fetal distress or not. Okay? So first one, acceleration. That's the normal acceleration will be usually 15. Usually it is secondary if the baby is moving. The baby needs more oxygen, isn't it? When you exercise, when you jog, you increase your heart rate, isn't it? And because of that increased heart rate, because your body needs more oxygen, the same is true with the baby. If the baby is stimulated while inside the uterus, or the baby is moving, they need more oxygen. Therefore, they need, of course, to increase their heart rate. It is just like as normal. But again, bottom line, as long as the increase in heart rate or the acceleration is not greater than 60. Clear? Okay, deceleration, decrease in heart rate. Usually, of course, deceleration about if the uterus contract. The baby, of course, is not being given, of course, enough oxygen, is that it? Therefore, the heart rate of the baby will be decreasing. Okay? Sometimes we do it because of that one. And usually deceleration will be fine. Okay? As long as the deceleration is not below 100. Okay? 100 is the math number. What is early deceleration? begins early in contractions, hits the low point at the peak of contraction, returns to baseline at the end of contraction, mirrors contraction pattern. This is the normal response of the fetus in labor. Clear? Okay? Shall we say, from the beginning of contractions, in the increment, acme, decrement, isn't it? From the start here, usually, of course, the heart rate that you are looking for is, shall we say, 130. Okay? 130 increment, you see, of course, a pattern. It went down to 125. It reaches here, it went down, of course, to 110. Okay? Up to here, of course, it was sustained. The heart rate, the strips will be at the bottom. Okay? You can see, of course, the heart rate. At the peak, of course, before the last peak, of course, you see it in 105. Okay? Here, in the decrement side of the contractions, you see, of course, it went up to 115. At the end, of course, of the relaxation, you get, of course, 132. We call that one is that changes, the decrease in heart, started, of course, in the increment. Before we call that one as your early. Because it's below the peak, the acme. Clear? Early deceleration, technically by definition, in order to portray it better, will be decrease in heart rate below 120, but not below 100. Okay? That occurs during the increment. What is increment? At the start of the rising of the contraction. Clear? And it goes back to normal at the end of the contraction, usually towards the decrement. Why? During this time, the placenta is compressed with the contraction. Therefore, the baby is not receiving enough oxygen. Usually, the baby's heart might be, of course, tendency, of course, for that one will be slowed down because you don't get any way, of course, any more oxygen. So the heart is responding, of course, to the contraction. And this is the normal pattern that we want to see in here, the tocodynamometer, as well as your fetal heart monitor here. Okay? So that's one thing. That is your early deceleration. In a day, in a meeting, in Mr. Deere's class, it is okay to be early, but never to be late. Because if you are late, you miss a lot of stuff. Okay? So what is late deceleration? Begins as the contraction eases. Now, to expose it, that one, of course, will be late. This is early. Late deceleration, at the beginning, is still basically 130, isn't it? Okay, 130. It goes here, of course, it's still 130, 132 at the acme. Deceleration, it went down, of course, to 105. So again, it occurs in the decrement. So is it early or late? Increment, acme, decrement. It occurs during this portion of the decrement when, of course, there's gradual cessation, of course, of the contraction. Okay? We call that one as your late deceleration. Okay? The heart rate decrease lasts longer than contraction in the resting phase. It went through here. Until here, the resting phase, it's still, of course, 101. God forbid, it went down, of course, to 98. The baby is in fetal distress, okay? And until such time for this one, it might go up, or it might be, of course, going up from here if the baby recovers. But again, what it signifies is that lasts longer than contraction into the resting phase. So even in the resting phase, remember, the fetal heart rate of the baby is in the resting phase should increase, go back, of course, within the 120 to 160. Because why? The uterus is relaxed. The baby could absorb more oxygen from the uterus, isn't that? So normally, during the resting phase, this is the phase, the resting phase, that is very important to allow the baby to suck on more the blood to survive during the labor process. But this time, the heart rate decreases. So we call that one late deceleration. Signs of a possible problem. Okay? So what does, of course, your book says if there's late deceleration? What's the problem? Anybody? What's the problem? What's the problem? And my question will be, as a nurse, if you see the pattern of late deceleration or decrease in fetal heart rate during, of course, the decrement phase of the contractions, what shall you do?
Need
Okay.
them to walk.
Nope. We're going to answer that one as we progress, okay? So what shall we do with the late deceleration? Another one is decreased variability, okay? Little fluctuations, of course, of fetal heart rate in the internal monitor, or it's a danger sign. No changes at all. What is that, Ms. Priska? What's late deceleration means?
He said begins as the
I know. That's why I'm defining. But again, my question will be, if you see that one, is it normal or not? Again, this is my question. You see early deceleration. It occurs during the increment. Is it normal? And the results, of course, at the end, of course, of the contractions. Is it normal or not? Or the question will be, in a more complex way, you see, of course, a pattern, of course, of a decrease in heart rate as the contraction starts and rises. And again, goes back, of course, to prescribed heart rate when, of course, the contraction stops. As a nurse, what shall you do? A, B, C, D, and E. Select all that applies. If you see that pattern, first one you identify, it is an early deceleration, isn't it? So what shall you do to the woman? Nothing. It is mere a normal response of the heart rate to the labor. What shall you do as a nurse? A, continue monitoring the woman. It's the best choice, of course, you can get because there's nothing you can do. There's no problem. No, but now the question will be, you are monitoring, of course, the tokodynamometer of the woman and the fetal heart as compared to the fetal heart tone. Okay, you notice, of course, that the fetal heart rate drops down. Okay, below the usual rate of the fetus when, of course, and you know that the start, of course, of the decrease of the heart rate starts, of course, usually when the contraction eases towards the resting phase. Now the question will be, is it normal or abnormal? Because the next question will be, what shall you do? As a nurse, you report it. I thought about the why, because you know, because what you're talking about here. The first one is that, is it, of course, normal or abnormal? Abnormal. Now, the next thing we're going to do is that what is that one? We call that one late deceleration. Late deceleration is abnormal because you know that it is okay to be early, but never to be late. Therefore, if it's a late deceleration, that is abnormal. Okay? So now the question will be, as a nurse, what is the priority thing you have to do? You are checking already the heart rate. We are looking at the heart rate, Ms. Priska. Now, my question will be, is there anything, of course, you can do to help the woman? Because if you were going to allow it, there might be, of course, some people distressed that we're going to go on with this one. What did the book says? We're already here, of course, in evaluating a fetal heart monitor. And again, late deceleration, what does it mean? Explain it to me. What is occurring?
Umbilical cord.
Is that?
Umbilical cord contraction.
The umbilical cord is being compressed. It might be that no, not only that one. If it's in the neck, it's fine. Such 4. Okay, now.
But you wouldn't document like how, what state the mother is in, like if she like
What do you mean by
makes it
that?
afterwards or.
Then we have, of course, to document it the next stage 3 or stage 4. The book of the things of the complication of the mother, we have documented one stage 4. We are the only in stage 2. The baby is only delivered. So it's all about the expulsion of the baby, that's it. So again, your episiotomy, the site or the method, is it medial or your mediolateral will be documented. In what time or what direction? 5 o'clock, 6 o'clock, or 6:30? Though there's no 6:30, only 7 o'clock, okay? Because 6:30 will be different, okay? Okay. Precipitous delivery is one, of course, of the problem because you precipitate delivery. That's one thing. From the contraction, first through labor, right away the baby is out. Precipitous labor, less than 3 hours it occurred. And we don't want it to happen because if that baby, of course, precipitous labor less than 3 hours in the onset of delivery to birth, injury to the cervix, injury to the baby might be imminent. That's why we don't want any precipitate labor and precipitate delivery. Okay? It will be spontaneous, but in a proper time, proper timing, no precipitate thing. Because again, all these things is only one thing, either injury to the baby or to the mother. Okay. Episiotomy, midline, mediolateral. And this is, of course, your cut. My favorite cut, of course, will be mediolateral. Okay? Because I'm right-handed. So this is the thing, of course, the crowning, the total crowning, of course, and your repair. Okay? And it's easier, of course, for us, of course, to suture this one. Again, when the baby is out, the first thing, of course, to do is that before, of course, the full dilation, of course, will be the nuchal cord. That's why fetal head, if it's fetal head, right away you slip, of course, the back of the baby. Okay? That's why you hold the baby, you slip on the back, okay, of the baby. But usually, of course, the first thing is with the baby's head first, suction right away. Okay? We need to suction that away the baby. Okay? Now, you check, of course, the neck, you slide, of course, in the neck. If we have, of course, the loop, we call that one nuchal cord. Commonly, of course, you just remove it around. If it is so tight enough that it prevent progression, of course, of expulsion, then that will be the time that we have to cut off. But again, we cut off the umbilical cord, the fetal head is out. So it is easier, of course, to deliver the baby. We only do that one. Sometimes I did, of course, a lot. If I have no severe, it is a double knuckle cord. So I don't have any choice but to clamp, and then cut in order, of course, to deliver the entire baby out. Okay? Nose and mouth suction. The most common question, which part do we suction first, the mouth or the nose? Answer me later. So again, my question, because the book says nose and mouth suctioning with the bulb, but the question is that will be, where do you suction first, the nose or the mouth, and why? Huh? So? Because they are mouth breathers, so you suction the mouth first.
Aspiration.
So what's the thing with aspiration? Yeah, I know. We don't want, of course, to aspirate more. As a matter of fact, we want to keep it out because, as a matter of fact, they have chest compression during, of course, vaginal delivery. But why we have to suction the mouth first? Is it because, of course, there are more volume, of course, of amniotic fluid trapped, of course, in the mouth than in the nose? First one is that. Ms. B, of course, says, of course, that because babies are mouth breathers. It might be. Okay? But if the mouth breathers, of course, again, they have to expand the lungs, of course, when they come out. Okay? So partly, of course, it might be true. But again, remember, when we suction the baby, it's only when we deliver the fetal head, we suction right away the baby. The baby is not yet breathing. Okay? Then the reason for that one is that if you suction, of course, the nose first, we have receptors on the nose. Okay? We call that one a gasping receptors there. So if you suction the baby's nose first, and you have, of course, a big amount, of course, of amniotic fluid in the mouth, the baby, of course, will gasp first and then suck back, of course, the amniotic fluid in the mouth. Volume-wise, there's a lot more in the mouth cavity, and you stimulate, of course, that gasping reflex. Therefore, suction the entire mouth first and then the nose, so that when the baby gasps later, at least there's nothing more in the mouth. That's why suction the mouth first, which is correct, but again, the main reasoning is that, okay? Suction, of course, the mouth first before the nose, okay? Baby will be handed to the mother immediately. That's why when the baby is delivered, suction, of course, when the baby, of course, cries, we give the baby, of course, right away to the mother, skin-to-skin contact. Okay? Bonding and everything will be enhanced during, of course, that period. Dry the baby. Observe the breathing patterns, cord clamp. And again, we have to do, of course, your APGAR score in 1 to 5 minutes. Okay? What is APGAR? This is, of course, the assessment of the newborn. Again, when we give the APGAR, is that we check the baby when the baby comes out on the first minute of life. APGAR scoring. And again, we assess the baby, another APGAR score after 5 minutes. Okay? The score of the baby, the perfect score will be 10. Okay? Again, commonly is that the baby score should be above 7. In any event, the baby, of course, APGAR score is below 7. Then, of course, the baby should be monitored and the baby could be resuscitated. That's why when the baby is being delivered, there should be a neonatal ICU-trained personnel besides, so that in the event, of course, that the APGAR score needs to be resuscitated, there's already, of course, somebody who knows neonatal resuscitation. Okay? So again, what are the areas that we check? APGAR, appearance, P, pulse rate, G, grimace. A will be, of course, what is A? Appearance, A is activity, and R is for respiration. What are these things? We have to discuss that one when we care for the newborn. But again, APGAR scoring should be given to a child. Any baby, of course, who have a score, of course, of below 8, shall we say 7 and below, is unstable until, of course, it's 4. Any baby born with a score of 4 and below needs to be resuscitated right away. I did deliver a baby with a 3 APGAR score. So what did I do? I have to resuscitate the baby. Okay? Did they bring the baby out? Yes. As a matter of fact, of course, he gets his family of his own right now. Okay? Staff person skilled in neonatal resuscitation to be available depending, of course, on the APGAR. So what is APGAR score? That is the score we give to the baby to make sure and to check, of course, their survival probability outside, of course, of the mother. Okay? Delivery of the placenta. Schultz, Duncan's. Are the all lobes present? Part of the placenta? Yes or no? Okay? If it is yes, make sure, of course, that placenta administering, of course, the medication to make sure that the uterus will be contracting. And that medication will be your oxytocics. Okay? Oxytocin is only given once, of course, the baby placenta is delivered. It could be in the form of methergin. Okay? But the best way, of course, to stimulate, of course, the release of oxytocin naturally will be to stimulate the nipples. And the best stimulator of the nipple, of course, will be the baby, to suck it off. Okay? So fundal massage, make sure that, of course, that after the delivery, of course, of the placenta, make sure again that the placenta is firm and contracting. Any globular placenta, baggy, placenta of uterus, it means that the uterus is contracting. It will gonna cause bleeding. Again, bleeding could occur in two things in a woman postpartum. One, retained placental fragments. But the great difference for that one is that if you feel, of course, the uterus is firm. The uterus is contracting. But there is still profuse bleeding because, again, we have these placental fragments. Another form of bleeding is that the woman is profusely bleeding and the uterus, of course, is so baggy, is too soft. What are the things we have to do, of course, as a nurse? First thing, of course, that we do is that massage the uterus. That's the first thing you have to do. Massage it. Okay? So when you massage it, if it contracts, the better. Another thing will be, of course, your ice pack. Okay? Once we have ice pack, it will cause, of course, contraction. And the third one will be administration, of course, of medication, just like your oxytocin, of course, in order to maintain the uterus cramping. Okay? If that will be, of course, not working, fundal massage, cold compress, or oxytocin to the mother, usually the doctor, of course, will be diagnosing hypotonic uterus. And that time, besides placenta previa, the woman is risk for bleeding. And usually the judgment for that one would be to remove the entire uterus. Hysterectomy is usually an indication, is usually a result of a hypotonic uterus, meaning to say it's not contracting, despite the fact that we give interventions right away. Okay? So stage 3, examination through the cervix. Again, why we examine the cervix? We don't want to see, of course, any laceration of the cervix. Okay? Vagina, episiotomy, laceration repaired, cleanse. Then episiotomy, of course, will be, we repair it during, of course, the care. We call that one ashore. Usually, of course, we call that one episiotomy. Okay? Appropriate perineal pads, cover the warm blanket because, of course, of hypotension. Mother's legs should be down. Always remember this one. Even it's in the stirrups, do not, of course, remove. Okay, we're going to go the right first, lower it down. Do not, because you're stretching the perineum. It's painful for the woman, okay? The trick will be, there's no gushing already with you in the front. So you can see, of course, face-to-face the vagina. Remove, of course, the legs, okay? Once you remove the legs from the stirrups, close it and lower down it simultaneously. Do not lower down the right or the left first because you're stretching the perineum. It will going to cause more injury to the perineal wall. Clear? So again, that's why bring the mother's legs down from the stirrups slowly and together. Okay? So sometimes, if it is, of course, LDRP, we remove, of course, the rubber, of course, raining pad, and then close it and cover it, of course, with a sheet, and then put the mother's legs down. Okay? And, of course, pull the stirrups, of course, on the sides, if it is LDRP. Okay. So again, so complete information, so type of delivery, sex of the baby, also, of course, not only document, of course, what is the baby, what's the sex of the baby. That's why sometimes, a lot of people, the most common one is that if your last name, of course, will be Bayawa, okay? So if this Bayawa, the hospital called it baby girl Bayawa. And I don't know why. Some people, of course, in the hospital, they don't know what's the name of the baby for the birth certificate. They didn't even ask for the parents, baby boy Bayawa. That's why they were just, here's the first name of baby boy. That's a real name. Not on that video, of course, baby, but you have baby Rosalie. That's the first, of course, your name. But you're not baby girl. But there's some documentation, of course, that I see, of course, in the birth certificate that the name, of course, of the first name. What is the last name? Bayawa. First name, baby boy. It occurs, believe me or not, it occurs in the real thing. That's why sometimes we have to amend, of course, with statistics office in order to change the name, of course, of the baby. Okay? With this, of course, Katulpo. Katulpo Bayawa. Okay? So, that's the name. Okay, check up all this time. What is this time? These are the things, of course, you have, of course, to measure. Okay? Warmth is needed, bonding, that's the stage 4. And again, the greatest monitoring in the stage 4 is that you check, of course, for all of these things, fundus, perineum, blood pressure, pulse, oxytocin drugs, and these are, of course, the metrogen and the oxytocin. What are the things you have to give? Fundus, rising may indicate uterine hemorrhage. So, not become firm with massage, report findings, located right to the midline. If it is right to the midline, make sure that the woman pees. Because if the woman doesn't pee, it will gonna cause, of course, the movement, of course, of the uterus to the right side. We call that one dextrorotation of the uterus. So if that will be the case, allow the woman to pee. If the woman should pee after birth, when? Within 6 hours. If not, report it right away. You have this problem, and it will gonna cause the uterus to bleed if it dextrorotate. Therefore, the woman has to pee. If the woman can pee by her own, next thing will be catheterization. We have to catheterize the woman if the woman didn't pee, of course, for the first 6 hours. Okay? Perineum stitches intact, no excessive bleeding, no edema, no bruising. Okay? Lochia. This is, of course, what is lochia? Vaginal discharges after the delivery of placenta. Okay? So according to your book, of course, we have some lochia there. Of course, the mother, we have to take, of course, the amount, the character, the color. Okay? Observe the voiding within 6 hours' time. Okay? Mothers thirsty and hungry, give them some food. Breastfeeding, newborn to breast as soon as possible, as much as possible. Alert at this time, stimulate breast, encourage, of course, release of oxytocin that could cause contraction. That's why breastfeeding the baby or let the baby sucking, not the husband, okay? Not the husband to suck with the mother's breast, of course, will be beneficial, of course, to the mother's system because it releases extra oxytocin. Extra oxytocin or high level of oxytocin ensures one thing, cramping or contraction of the uterus. Contraction of the uterus means only one important thing, no bleeding. Clear? Okay. Postpartum, first 6 weeks. That's why no sex for 6 weeks. Okay? Overall state appetite for that one, and this is the time, of course, usually, of course, postpartum depression will be common. Oh gosh, that's one thing. That's a normality, of course, of labor and delivery that we're going to talk about. Some women, of course, kill their infants, their neonate, of course, because, of course, of postpartum depression that went into postpartum psychosis. Okay? Most common one, the most common is that, that baby is not my baby. That's the baby of the devil. I saw, of course, the fans and blah, blah. That's their, of course, delusion. Okay? What they do? Bring the baby out of the window and throw it out the window. You see the documented, of course, things in the report that is occurring. Actually true. We call it one postpartum psychosis, which we have to handle, of course, in abnormal pregnancy and labor and delivery. Okay? Involution after delivery, of course, of the placenta, 2 pounds. Pre-pregnant state, 2 ounces. So the uterus will be 2 ounces, of course. Okay, in the usually finger width, of course, it has, of course, at least 1 to 2 finger widths, of course, that will be, of course, decreasing and voluting, of course, below, of course, the umbilicus. Okay? So 2 ounces, 50 grams, midline, firm. Okay, so abnormal, deviated to the side, soft and baggy, these are things. Deviated to the side, let the woman pee. If not, if the woman didn't pee, then catheterize. Soft and baggy, first thing you have to do is massage. Okay? It has to be firm. If not, then you have, of course, to put some ice pack to maintain it. If not, oxytocin could be delivered by the doctor or by you, okay? But again, if it does not respond, then you have a big problem, okay? So these are, of course, the necessary documentation of postpartum woman, okay? So first one is that, the lochia. We have 3 lochia. Oh, it's 8:36, sorry. So I would just like, of course, to finish the lochia, okay? Lochia is the discharges, of course, of the woman, which is very important to me because you have to monitor this one, okay? Terms will be RSA, rubra, serosa, alba. If you were going to read your book, it's a little bit hard, but it's, of course, the easiest way. First, 48 hours, 1 to 2 days, lochia, rubra, bloody, okay? Should smell like blood, seen in the first 2 days. Day 3 to day 9, the next 7 days, according to your book, serosa. Bleeding diminishes, slightly earthy odor, brownish a little bit, okay? But it's earthy odor, not foul. Foul means infection. Okay? Earthy odor, color changes from pink to brown tinge. That will be the progression. In the amount will be, of course, lesser and lesser. Okay, next 7 days. And at day 10 onwards, this should be yellow or white. There's a tinge, of course, that one, yellow or white. Amount decreases. Again, earthy smell still. Never foul. A foul lochia means only one thing. Infection. Okay? So RSA. So rubra, serosa, alba. Okay? So these are the abnormalities. Check, of course, for the cervix, no weight loss, colostrum, lactation. So you just, of course, read through for that one. And the most important in lactation, of course, will be prolactin to produce, of course, the breast with milk. Okay? Engorgement. So most of these things, of course, we're going to talk, of course, when we reach, of course, of normal things. Okay? Any questions? Any questions so far? Now? You are so eager to go home? So of course, when you leave, of course, and then go home, and then wishing you, of course, happy holidays. So see you next year.